Okay, let's start for today. First of all, what I will do, I will right now provide you with a script on the WhatsApp group for each station that we are discussing. But this will apply only for the first 8 stations. The next 4 ones or the next 5 ones, I will provide you tonight because I did not finish them, but they are quite similar to the others. I will be slow while repeating them so that you can write after me. Actually, I'm already slow, I think. So you will be able to write after me every and anything you wish. So no problem. Let's start right now with the meningitis station. Your FY2 working in A&E, okay? Before starting, my voice is quite clear because after finishing the session yesterday, some people complained of the clarity of the voice. So everyone, my voice is clear right now. I do not want someone to be silent and to not tell me that my voice is clear after finishing the session, okay?
Clear, yeah. Clear.
Okay, perfect. And please, everyone, mute their camera. Videos are not allowed. Okay? Okay, so let's start. Your FY2 working in A&E, guys. The patient is a 35 years old female patient presented with severe headache. So the presentation here is severe headache, okay? This is the only presentation, and the task will tell you that you will find news chart inside the cubicle. What will we find? We will find news chart inside the cubicle. It is written in in high case. I mean the word news chart, it is written in high case. Do you understand what they mean by high case? Like, for example, it is written like I'm going to write it to you right now. Wait. I'm going to write it to you. It is written like this. In the task, they tell you that you will find news chart inside the cubicle. Why they write this? This means that usually the news chart is very essential in the diagnosis of this station. Okay? Why? Because you will see right now. Exactly, Dr. Yasmin. Dr. Mahdi, you can tell me, you asked someone else to join, right? Your wife. Where is she? Did she join or not? I think she did not join. Dr. Mahdi, you can unmute yourself and speak right now to save the time. Because we are going to start. Once we start, we'll be quite fast.
No. Ahmed, here, Ahmed.
Your voice is
join by 5 minutes.
Huh?
Okay, she will join by 5 minutes. She's going to join, but she's outside. Actually, I thought it was started after half an hour late, but fortunately, it started half an hour earlier. That's why. Actually, she's missing currently. She will join within 5 minutes.
Okay, no problem, no problem. I was just checking who joined and who did not. Okay, so you can mute yourself right now.
Okay, she's joining.
Okay, no problem. Okay. So, Doctor, so anyway, the news chart, it will be written in high case. You can mute yourself right now, Dr. Mahdi, please. Okay. It is written in capital letters. The moment you will enter, you will greet yourself to the examiner, as you all know. Okay. After greeting yourself to the examiner, what I suggest, go and pick up the news chart from the table. Some people may disagree with me in this, and I'm telling you, I'm begging you to pick the news chart from the table. The patient is lying on a couch. What you can do here, before proceeding to the patient, just pick up the news chart from the table, read it out loud. For example, I can see that my patient is having, like, for example, oxygen saturation is 95, blood pressure is something, breathing rate is something, body temperature is something, which is high. So you will read out all the vitals loud, okay? Why I reading it out loud? Because I need to show the examiner what I picked from the vitals. Okay? Okay, we will see right now. So you read it out, the vitals loud. After reading the vitals loud, you will find that the patient is feverish, and quite feverish actually. So now you will say, I assume I have taken all universal precautions. Okay? Okay. After taking universal precautions, move to the patient. Hello, I am Dr. XX, one of the junior doctors here. Can I confirm your name, please? There could be two scenarios. She's either conscious or unconscious. If she is conscious, she will tell you, Doctor, my name is Anna. I'm 37 years old. Nice to meet you, Anna. How can I help you? She will tell you, Doctor, I'm having severe headache. Now you will assess the patient comfort. What if she is unconscious? If she is unconscious, how can I help you today? She is not replying. What you can do in this case, you're going to tell her that, are you in pain? Okay, I'm going to give you painkiller. The examiner will ask you, Doctor, which painkiller? You will say, after ruling out contraindications and drug allergy, I'm going to give my patient IV paracetamol 1 gram. So what came to me was she was unconscious, but in some other cubicles or some other candidates, she can be conscious. Okay, so do not forget about that. I'm even writing it on your notes, the notes that you will follow, inshallah, that she can be conscious or unconscious. If she is conscious, you will elaborate the headache. But if she is unconscious, you are lucky because you will not ask her any question. You will just tell her, are you in pain? She will not reply. Okay, I need to give her painkiller. The examiner will ask you, which painkiller, doctor? You will say IV paracetamol 1 gram. After ruling out contraindications and drug allergy. Okay, assume, doctor. Hello, I have given you painkiller. Are you feeling better right now? Is there anything bothering you? She's putting her hands over her eyes, which means that she's trying to hide her eyes from the light. So what are you going to do right now? Is there anything else bothering you? Is the light bothering you? And please, when you are asking these questions, try to give space. Don't go like, for example, is there anything bothering you? If the light is bothering you, would you like me to dim the light? No, please give space. Like, is there anything else bothering you? Is the light bothering you? Would you like me to dim the light? Okay, examiner, I need to dim the light. Here the examiner may tell you, okay, doctor, assume, or she may tell you as well, doctor, you are in A&E, you cannot dim the light. So what are you going to do here? You're going to do simply moving the patient to a separate room. So I'm going to shift my patient to a separate room, doctor. Okay, the examiner will tell you, assume, doctor. Remember that you shifted her to another room in which the light is dimmed. You dimmed the light. You dim the light. Always remember this point, because this point will give you a blunder later. Okay? So, now I dim the light. Can you take your arms away, please? Can I help you with doing this? So, usually she will let you take her arms away gently. Do not be too fast while doing this. You just have to take her arm gently. Okay, if you do it quite fast, actually, she will give you a bad vibe. Why a bad vibe? Because she's really in pain. Okay, so please do it slowly. So, you took her hands away or her arms away. She will tell you, or he will tell her, okay, so we will be quick now. So thank you for bearing with me. So now you took her hands away and her eyes are uncovered. Okay, and you dim the light and you give them painkillers. What you can do right now, by the way, there is something very important. This patient is presented right now so far with fever and headache and photophobia. So now you almost knew that this is meningitis. You do not need to take more data. What you can do now is to assess her consciousness, because actually your history was quite enough. Your data gathering was quite enough to know that this is meningitis. You picked up from the news chart the fever, and you picked from the history or from the findings headache and photophobia. Those triads are quite familiar for meningitis. So now move to the GCS. What you are doing in the GCS? In the GCS, simply, you're going to ask the patient, can you open your eyes and keep them open for me? Do not forget to ask, keep them open for me. Usually the patient will try blinking her eyes gently, which means that she is trying to open the eyes, but she cannot keep them open. So I will give her 3. But if she is opening her eyes, I will give her 4. If she is not, if she is not opening or keeping them open, you can simply pinch her eyes from above a little bit, but gently, which is response to painful stimuli. Okay, so usually she will take 3 in the eye response, unless she is conscious. If she is conscious, simply, definitely she is already opening the eyes, so you do not need to do the GCS here. If the patient is conscious, usually we do not do the GCS. Okay, she can be a little bit confused, but you do not need to do the GCS if she is pure conscious. Why? Why? Because actually in the GCS, if she shows you signs of confusion, you can do the GCS, right? If she's conscious and she's a little bit confused, but usually she's unconscious, so you need to assess the GCS. So you assess the GCS only in 2 cases. Number 1, if she's confused and conscious. Number 2, if she's unconscious. So we did the verbal response right now, right? Let's move to the next. Sorry, we did the eye response right now. Let's move to the next, which is the verbal response. In the verbal response, simply, you will do one thing. You will ask her, do you know where we are? She will usually tell you one of the responses. If she asks you or if she tells you, doctor, we are in the hospital, this means that she replied relevantly. So she deserves at least, she deserves here 5. Why? Because she responded, she responded wisely. So what if she tells you, I am a woman? This is a relevant answer, yet it is a complete sentence. So I will give her 4. What if she tells you, for example, what if she tells you that cat, dog, hospital, patients, those are scattered words. So this means that she deserves 3. What if she tells you, she is mourning, which means that she deserves 2. Okay, this is the GCS simply. It's very simple. Okay, let's move to the challenging step, which is the motor response. Can you raise your right arm for me? Can you raise your left arm for me? Can you raise your right leg? Your left leg? Can you stick your tongue out? So you will assess the 4 limbs, and after that you will ask the patient to stick the tongue out. Why? Because usually you do not know history about the patient. She may be quadriplegic. If she's quadriplegic, she may not be able to raise any of her limbs. So you'll usually ask to stick the tongue out. And by the way, there will be no response at all in the verbal response. So you are going to tell her, sorry, in the command, on the verbal command. So now you're going to tell her, okay, I'm going to pinch or I'm going to touch your thumb right now. So please bear with me. Once you pinch or you touch her thumb, she will give you one of the responses. She may either push your thumb with the other hand. For example, if you are pinching her right hand, she may push your thumb by the left hand. This is what we call localizing pain, which means that she was able to localize where the pain is coming from. So we're going to give her 5. What if she simply, in this case, she withdrew the right, the hand that you are pinching. For example, you are pinching the right and she withdrew the right hand from you. This is what we call flexion withdrawal. So we're going to give her 4. What if she withdrew both hands? Like for example, you are pinching the right hand and she pinches the right, she withdraws the right and left hand away. This means that she was flexing. Yes, she was flexing, but this is abnormal flexion. She was not able to flex the relevant side, so she flexed both sides. So this we call abnormal flexion, and she deserves 3 in this case. What if she does abnormal extension? Abnormal extension, which means that she let her both hands fall to the side of the bed. I will tell you right now everything, Dr. Murad. So abnormal extension means that she let her hands fall to the side of the bed. This means that she deserves 2. Okay, this is the GCS sampling. You are going to keep the score in your, no, you are going to keep the response in your mind. For example, you are going to remember that this patient was trying to open the eyes but could not keep them open. You are also going to remember that this patient has given me flexion withdrawal, for example, or localizing pain. And you're going also to remember that this patient was saying, for example, mumbling or scattered words. Mumbling is scattered words, by the way. Moaning is So you will remember the response in your mind, and now you excuse yourself from the patient, even if the patient in PLAB 2 is unconscious. You will now excuse yourself from the patient right now. You will go to the table. The table usually contains a GCS chart. So you will pick up the GCS chart and you will read it out loud. You will say, my patient given me X motor response. So I will give her, for example, 5. My patient has given me X in verbal response, so I will give her, for example, 3. My patient has given me X in eye response, so I'm going to give her, for example, 3. So you are going to score upon the chart that you are going to pick. So the total score is, and you will calculate. So you will only remember the response, but when you will score, you will pick up the table, the GCS table, or the GCS chart from the table. It's usually on the table beside the patient. Yes, there will be 2 charts, news chart and GCS chart. And by the way, the GCS chart is flipped on the table. Like, for example, it's not clear, so you have to go and find it yourself. Okay, because the examiner knows that you can be smart, and when you are picking the news chart, you will know that there is GCS chart. She doesn't need you to know that there is GCS chart. She needs you to find it out by yourself. Yes, there are 2 tables, Dr. Murad. One for news chart and one for GCS. Okay. So next step, now you know that the GCS is quite low or a little bit low. It's usually above 8. If it is below 8, you are in trouble. It can never be below 8. So please remember that the GCS can never be below 8 in this case. If it is below 8, you are in trouble. Okay. What are we going to do right now? We are going to do the neck stiffness. How to do the neck stiffness? We're going to ask the patient to touch the chin to the chest. Why? Because this is assessment of the neck stiffness. Touches the chin to the chest, she is not able to do it because it's very painful. So I'm going to help her with that. I'm going simply to help her touch her chin to her chest. Flex the neck a little bit so that the chin touches the chest. But please be gentle and please look at the legs. You are flexing the neck while looking at her legs. Okay, you will find usually she is flexing her knees and she is saying, ouch. When I did this, she gave me a scream. I mean, I think anyone who's coming from the Hardman Street, which is a GMC building street, they could hear it. She was screaming very loud, by the way, this patient. Okay. So she will get, this is what we call positive Brzezinski sign. Flexing the neck elicits hip and knee flexion. This is Brzezinski. Let's move to the Kernig sign. You're going right now to flex her hip and extend her knee. For example, you are flexing her hip right now. Hip flex it, now extend the knee. Extend it gently while observing the other leg. For example, you are doing on the right side, observe the left side. You will find the patient is raising her other side or raising her other legs as well out of pain, and sometimes flexing the neck as well. So Kernig sign means that knee extension elicits hip flexion and knee extension on the other side. And sometimes she can bend her neck as well. So this is Kernig sign. Now move to the other part, which is the rash. So now we did knee neck stiffness. Now find the rash. So please, I told you that you dim the light, which means that you will never be able to see if there's any rash or not. So you need a torch to find the rash. So you'll find on the table there's a torch. What will you do with the torch, guys? You will open the torch by yourself. You will open the torch by yourself, please. And after opening the torch, she will not help you, the examiner. After opening the torch, by the way, what you will do, you will assume that you are looking for a rash. The examiner may tell you, doctor, there is no rash in the exposed areas. Okay, some people may say, this means that there is no rash. No, she means that there is no rash in the exposed areas. What are here exposed areas? The patient, sometimes the chest, the upper chest, sometimes as well the neck, and the ear, of course, and the armpits sometimes. So this means that there is no rash in the exposed areas. So there could be a rash in the non-exposed areas. So you are going to look behind the ears. You are going to look deep. Like, for example, you are going to peer in the chest. You can find the rash, by the way. So what you will do, you will say, I could find rash. I need a glass. The examiner will tell you, doctor, why do you need a glass? Because I need to perform the glass test to see if the rash is blanching or not. Okay? The examiner will tell you, doctor, the rash is not blanching. Okay. Now I have 5 findings. Number 1, fever. Number 2, headache. Number 3, photophobia. And number 4, there is GCS, low GCS, which means confusion. Number 5 is neck stiffness. And number 6, there could be a rash as well. By the way, the neck stiffness is elicited or approved by Brzezinski and Koenig sign. So now I have many findings. The examiner will ask you, doctor, what's your diagnosis? You will say, I'm suspecting that my patient is having meningitis. Why you think so? Because from the history, my patient is having headache and photophobia. From the examination, the news chart shows fever, and the GCS is low, which means that the patient is confused, and there is neck stiffness proven by positive Brzezinski and Koenig sign, and there is a rash, which is non-blanching. Non-blanching means that if you put your hands over it, it doesn't pale. It does not become pale, which means that it's most probably non-skin lesion. It is a rash due to fever. Okay, okay. So you said why meningitis? She will ask you, doctor, what are your differentials? Differentials for meningitis. I need someone to answer me. What could be the differentials for meningitis, guys? Dr. Masin.
Subarachnoid hemorrhage.
Okay, good. What else?
GCA.
Perfect. What else?
Glucoma maybe.
Okay, good. Migraine as well?
Migraine.
SOL. Okay, thank you, Dr. Masin. So the DDs are GCA, okay? Subarachnoid hemorrhage, those are the most relevant DDs. You can also say migraine, you can also say SOL and glaucoma. Okay, so the examiner will ask you what are you going to do right now. Number 1, for the meningitis, you are going to admit the patient and isolate in a separate room if she was not isolated yet. Okay. Number 2, you will ask the senior to come and review. Number 3, give painkiller. Okay. You're going to give a painkiller if you did not give it already. Okay. You're going to give a painkiller if you did not give it already. This is important. And you will going to monitor her oxygen and IV fluids. Why I'm going to monitor the oxygen and IV fluids of the patient? Because, guys, remember, those who attended my SIMMAN explanations or SIMMAN classes, in any case in the medicine, any case in the world, you'll always start with ABC. In any case emergency, you will start with ABC. Okay, okay. So the ABC here are the most relevant. So I'm going to focus more on the oxygen and IV fluids in the beginning. After oxygen and IV fluids, I'm going to Very important, perform some investigations. Which investigations you are going to perform, doctor? I'm going here to perform some bloods, some urine, and some scans. You will say all the routine bloods, full blood count, liver and kidney function test, blood culture, everything, all the routine blood counts. Why? Why this is important? Because actually this could be a sepsis case. The patient may go into sepsis in a while. Remember, this is meningitis. So you will do all the bloods, okay? After the bloods, what you will do here, you will do the urine and you will perform CT scan. Why CT scan? She will ask you this question. Doctor, why CT scan?
To rule out contraindication for lumbar puncture.
Definitely. So to rule out contraindications for lumbar puncture. Okay, okay. Then we can perform the lumbar puncture, which can confirm the diagnosis of the meningitis. After confirming the diagnosis of the meningitis, we can start the antibiotics according to hospital protocol and senior review. So please, whenever you are starting the treatment here, you'll always say that I'm going to do it upon senior review. So senior review and hospital protocol are very important before prescribing any antibiotics in the PLAB tool. And I'm sending you a photo now for the meningitis notes. So we will start antibiotics after according to hospital protocol and senior review. Then what we will do, we'll trace the contacts. Why tracing the contacts? Because I'm not sure if his contacts or if her contacts has caught the disease or not. Okay, so please make sure that you do not forget about that. So trace the contacts and seek microbiological advice. Do not forget to seek microbiological advice for the contacts as well, because they may need prophylactic antibiotics. Remember from tab 1, rifampicin. But do not say rifampicin, just say prophylactic antibiotics. Okay, okay. If anyone is having any question, guys, please you can ask in the end. Okay, today is a little bit tight session, so we do not need to answer many questions in one go, but simply the contraindications of lumbar puncture are raised intracranial pressure. If you are putting a needle in something which is inflated, the patient will boom, explode. So if there is intracranial pressure, you cannot put a needle in the spinal canal. Okay, so lumbar puncture, contraindication is the raised intracranial pressure. I sent you the notes on the WhatsApp page. I'm writing in the notes in the beginning, by the way, I'm writing for you that you know this symbol of danger. Why danger? Because this is one of the hardest stations. Many people feel it. Number 2, the news chart. I wrote the news chart in a very big letters in the beginning. Why? Because I know that most of the people forget to pick. You know what? I was told that by someone that actually, you know, in the news chart, in the registration, if 40 candidates took the exam in the same day, at least 30 of them will forget to pick up the news chart. Most of them will pick the news chart after finishing the next stiffness and rash and everything. And even some of them may forget to pick it throughout the whole station. So please do not forget about it. Okay? And I wrote you in the middle, do not forget to pick up the GCS chart as well. Okay? Okay. So the 6th step is tracing the contacts and seeking microbiological advice. Now you'll observe the lactate. Why? Because I told you there could be sepsis. So you need to monitor the lactate, serial lactate, every 1 hour. And according to which you may continue IV fluids. Last step is to give steroids to prevent the brain swelling or inflammation. In any neurological problem, you're going to give steroids to prevent the brain swelling or inflammation. Okay? So 8 steps. Number 1, admit and senior review and isolate. Number 2, painkillers. Number 3, oxygen and IV fluids according to the vitals. 4, perform investigations, including CT to rule out contraindication for lumbar puncture. 5, start antibiotics according to hospital protocol and after senior review. 6, trace the contacts. and seek microbiological advice to give prophylactic antibiotics. 7, observe the lactate. Okay, and you can monitor it with IV fluids. 8, give steroids to prevent brain inflammation and swelling. Fair enough, fair enough. If you give this station, by the way, if you seriously, if anyone has got this station in their exam, and they do not, I will follow all of you, and I will follow the results of all of you, inshallah. I mean, if we are like plan to live. But if anyone seriously do not score good or do not pass this, at least pass this station, oh, I don't know what to do seriously, because I explained to you everything in it. I explained to you the tips and the tricks in it. Only one thing I forgot to tell you here in this station. Sometimes, and this is very rare to happen, the examiner may ask you, doctor, you go and dim the light yourself. This may sound ridiculous, but this is really challenging. Why? Because the examiner now has got away from the medicine. She's asking you to dim the light. Why? Because she needs to know how you can dim the light. So you are going to dim the light and you will find a surprise. The socket of the light is not the usual socket. It's not a button. It is a socket like rotating. People who live in UK know about it, but people who do not live in UK, they cannot know about it. So please learn how to dim the light in UK. Okay, I know someone who did not pass it just because he could not dim the light in it. This is unfair, but it happens. So this is a station so far. Very easy station, but it's challenging. By the way, see, we took in it like 20 minutes, maybe 20 minutes or a little bit more than 20 minutes. But believe me, you will finish it in less than 6 minutes in the exam. Less than 6 minutes, seriously. It's less than 6 minutes. So please take your time in this station. Do not rush. Do not rush, and please be energetic. Be energetic in this station. For example, do not go like, okay, I'm going to dim the light for you. No, this is an emergency. You have to be energetic. Okay, a little bit. Okay, I'm going to dim the light for you right now, so please bear with me. Like this, if you're really in emergency. Okay, so next
Sorry,
station.
Dr. Ahmed, if I miss, do we need to give a call to neurologist also?
No, no.
No?
No.
Okay.
Okay, next station is a subarachnoid hemorrhage, which is quite similar to this station. This is quite similar. Okay, the only difference is that instead of the fever, you will find the high blood pressure or the hypertension. So the task will tell you that you are FY2 in A&E, and the patient could be 40 something years old, presented with headache. This is the only presentation. Okay, so she is 40 years old female patient presented with headache. So this means that when you enter, you will know about the task. I do not believe to tell about, I do not like to tell you the full task. Why? Because if I'm telling you the full task, it will be scripted. And you will be building your script upon the task. And I do not want this to you. What I need you to do is that you only follow the presenting complaint. What is the presenting complaint here? What is the presenting complaint? Okay, Dr. Islam, do you have a problem with my voice? You can say, what was the problem, or where was the problem exactly? Okay, okay, that's good. Excuse me, guys, where is Dr. Fumbi? Dr. Fumbi, not Fumzi. I think she did not join yet, because she asked me a while ago. She's trying to join. So excuse me for 1 minute. I'm just needing to confirm, because maybe she cannot join. Give me 1 minute, guys. I'm sorry. Yes, Dr. Zaid is here. Give me 1 minute. Okay. So the thing is that in this station, the patient is presenting complaint is headache. Okay, and you will elaborate the headache. How can you elaborate the headache? Now I need someone to come with me to elaborate the headache, please. This station will barely take us 10 minutes. So I need someone to come and elaborate the headache to me, please. Who can?
Okay, I can do that.
Okay, Dr. Masih, tell me, doctor, I'm having severe headache.
Okay. Are you comfortable at the moment you talk to me?
Yes, I am, doctor. No, doctor, no, I'm not comfortable. Please give me painkillers.
Okay, I'm going to give you some painkillers after ruling out some contraindication. But before that, let's have a quick chat about why you have been having this. Is it all right?
Yes, okay. It's fine, doctor.
Okay. So could you please tell me since when you have been having this?
Okay, now you made a mistake, Dr. Masih, and I was waiting for that. Your mistake list is counting. So this is the first mistake, and I'm writing it down. Didn't I tell you many times before to ask open question in the beginning? So, Dr. Masih, one mistake.
Could you please tell me a bit more about this headache?
Yes, anyway, I counted it. Do not fix yourself. Yes, that's what I'm being saying.
Okay.
Tell me more about this headache. Oh, doctor, this pain or this headache started like maybe 2 hours ago. Doctor, I was watching TV and it started like in the back of my head, but right now it's all over my head. It's the severest and the worst headache I've ever had.
Right. And is it relating somewhere else?
No, doctor, it doesn't go anywhere else.
Okay, and is there anything that is making it worse or better?
Ask one question at one time. One question at one time, okay? Anything makes it better, then anything makes it worse. Why? Because you are confusing the patient if you ask two questions. Okay? The patient may put you in trouble and they may tell you, yes, doctor. So you will tell the patient, yes, what? She will tell you, yes, what you asked me. This patient is not really concentrating. So do not ask two questions. Just ask one question at one time. So ask me again.
Okay.
Anything.
Is there anything that is making it better?
No, doctor. I tried some paracetamol, but it did not help me.
All right. And is there anything that is making it worse?
No, doctor. There is nothing, doctor. But sometimes I feel that the light is bothering me as well. So,
right.
Dr. Masih, simply, this patient is showing you that she's having headache and
photophobia.
Exactly. You forgot two questions. You forgot to ask if it's continuous or comes and goes. Guys, let's be honest. Who did not check the notes of yesterday? Dr. Masih, did you read the notes?
Yeah, I did.
Promise?
Yeah, I did.
Okay, so if I pick anyone in the middle and they could not elaborate the pain or elaborate any other complaint, the mistakes now are counting. Yes, I know that I sent handwritten version, but I believe me, it was really organized and you do not have any excuse to not read from it. And I will scan it, by the way. I do not say that I will not, but please make sure that at least you give a quick glimpse to what we said so that our efforts will not go in vain. Okay? And from now on, the list of mistakes is counting. So Dr. Masih has made one mistake. 5 mistakes equal 10 pounds. Fair enough, Dr. Masih?
All right.
This is a package. Okay, this is a special offer. So,
yeah.
Dr. Masih, continue. Now you're asking me about the relieving factors and aggravating factors. What else you can ask?
Okay. Could you please score this headache on the scale of 1 to 10?
Before scoring, don't you need to ask about if it's continuous or not?
Yeah, you already said no, then I forgot that.
No, I said it's getting worse, but I did not say it's continuous.
So, is it there all the time or it just comes and goes?
Yes, doctor, it has been there since it started.
Could you please score this headache on the scale of 1 to 10?
Okay, now she will give you very high score. She will give you at least 8.
Okay.
Do not ever underestimate that. Okay? So what if she gives you a score of 8, Dr. Masih? What will you say?
I can't imagine. I can't even imagine what you must do.
MashaAllah. No, now I am canceling your mistake. Seriously. I like this. So really, this is.
I know it's tough at the moment, but I'm gonna be very quick.
Yes.
I'm gonna start it out as soon as possible.
So now if she give you high score, you'll tell her that, oh my God, this is quite high. I'm seeing, or no, don't say, oh my God, of course. Just you're going to say, I can imagine how it could be painful, really. I'm going to make it quick. Please bear with me. So now you are encouraging her to bear with you, or at least you are validating her pain. Okay, very good, Dr. Masih. So now your list is back to 0. Okay, so what's next, Dr. Masih? She gave you photophobia in the middle. What if she did not show you, or she did not tell you photophobia, but she is showing you that the light is bothering her and she is hiding her eyes with her arms or covering? What will you do?
Okay, so I'm gonna ask, is the light bothering you at the moment?
MashaAllah, Dr. Masih. Great. So what's next? She will tell you, doctor, yes, doctor, it's bothering me.
Would you like me to dim the light?
Assume, doctor. The examiner will tell you. So thank you, Dr. Masih, for this participation. Quite nice. You made a mistake in the beginning, but I canceled it for you because you did 2 steps. Very good. So you can mute yourself right now. So this patient has given you headache and photophobia, and you elaborated it, right, guys? Right, perfect. Those are the 2 presenting complaints. Usually, when there is a patient with headache, we ask a few questions. What are the few questions? You know that this headache is most probably due to neurological symptom. Why? Because she's showing you photophobia as well. So you will ask about nausea, vomiting. You will ask about the 4 important symptoms for the headache. What are the 4 important symptoms? They are written in the notes. The 4 important symptoms are neck stiffness, weakness. Very important, guys, to ask about the weakness and the neck stiffness, because those are the core of the neurological complaints. If you miss them, I'm not sure about what will happen, because some people actually, you know, they will go like headache and photophobia. Okay, so let's jump to the past medical history and let's speak about the management and let's manage the patient. Especially this patient is giving you very tough time because she's real pain. Like, you know, this is the severest form of pain, guys, by the way. So this patient will make your life as hell. So what are you going to do? Simply, I'm sending you right now a photo for that. Please read it quickly or give it a quick look, and you will see that this station is quite easy. Guys, I'm making some notes in the middle. Which notes? You know what? I'm writing, like, for example, positive and negative. Positive and negative means that they can be present or not, but you have to ask about them. I'm writing question marks beside each differential diagnosis. Why? Because I need you to keep 2 questions for each differential. For example, for the meningitis, I need you to ask about fever and rash. For the GCA, you will ask only about the jaw pain. You will complete it by yourself. So I make sure that you are concentrating with me while I'm explaining. Okay? For the stroke, simply you're going to ask any facial weakness. For the SOL, you're going to ask any morning headache or blurry vision. Very enough. 2 symptoms or even 1 symptom for each DD. Those are the DDs and the associating and the presenting complaint. Now let's move to the past medical history. What is the past medical history or the maftusa? We are going to ask her, have you ever had this pain before? Sometimes she can tell you that, doctor, I'm having migraine, but this is even worse. So now she's giving you a hint that this is the worst form of headache she's ever had. Right? She's telling you, doctor, wake up. This is subarachnoid hemorrhage. She's giving you cues throughout the whole station that this is subarachnoid hemorrhage. Why I'm stressing on that? Because there is another station of migraine which will confuse you a little bit with it. What is the difference? We will speak in the end. So in the past medical history, you will usually find the patient is hypertensive. How to ask about the past medical history, Dr. Zaid? Quickly, I need you to ask it quickly. Dr. Zaid?
Yes, I'm with you.
Asking me about the past medical history, please, quickly.
Can you tell me, did you have the similar symptoms before?
Yes, doctor, I'm having migraine, but this is not the headache that I used to have before.
Okay, do you have any medical problems?
Yes, doctor, I'm having high blood pressure, actually. So how you elaborate it quickly?
How do you, is it control?
No, Dr. Zaid. We ask first, how is it managed?
How is it managed?
I'm taking ramipril, Dr. 2.5 milligram twice per day.
Yeah, twice per day. And did you recently change medication?
No, doctor.
Okay, and do you follow your, do you measure your blood pressure?
Yes, doctor. Okay, so Dr. Zaid, wait. Starting from tomorrow, inshallah, everyone, if you do not, okay, I'm giving you today only chance because sometimes the paper, or I posted the paper a little bit late. But starting from tomorrow, guys, please, everyone, read the notes because I do not need to take more than 1 minute in each question. Okay? Okay, that's perfect. No problem, Dr. Zaid. So, okay, so let's speak about the history again. Hypertension, you will elaborate the hypertension very good. How is it managed? Are you taking it regularly as prescribed? Do you miss any dose? You can say, is it controlled or not? Do you have any symptoms like any headache or blurry vision? Do you experience any of the complications like swelling of the legs or the knee? Sorry, swelling of the legs only. Do you follow up with your GP? This is the elaboration of any long-standing problem which we spoke about yesterday. You will ask here also about diabetes and high cholesterol because those are sometimes symptoms of any cardiovascular disease as well. So do not forget to ask also about the family history because sometimes it can run in family or it can be there is a family precipitation. Do not forget to ask about the lifestyle, especially smoking. Okay? Do not overlook the lifestyle. You could see it in the notes. I sent you the notes. Why I'm writing some like exclamation marks? Because actually in the lifestyle, many people will miss it in this station because the history may sound a little bit tricky and long. Do not forget to ask about it. And in the past medical history, you will find an alarm behind the word hypertension. Why alarm? Because simply this is the core of this patient. If you do not know that this patient is having uncontrolled hypertension, you will not pick up that this is subarachnoid hemorrhage. Now you can move to the examinations. In the examinations, we agreed yesterday that you can say number 1, vitals, including 1, 2, 3, 4, 5. If you do not explain the vitals, the examiner will not show you the news chart. Usually, the examiner will give you a news chart, you will read it out loud, and you will say that I could see my patient is having high blood pressure. Usually, it can be above 140 over 100. General physical examination. How do we say the general physical examination, Dr. Muniba? Dr. Muniba?
Hello.
Yeah, hello. Tell me how to say the general physical examination.
We can say I'm now going to have a look at you from head to toe.
Thank you, Dr. Muniba. So I'm going to have a look at you from head to toe. Now I'm going to do neurological examination. The examiner will ask you, Doctor, which examination? I'm going to assess the level of consciousness through the Glucoma scale and neck stiffness, including Brzezinski and Kernig sign. Okay, so the GCS similar to the examination in the meningitis. Okay, the examiner may give you finding. So I need to do some investigation. Which investigations, doctor? I need to do routine bloods, including, again, full blood count, liver and kidney function test, and a blood culture as well. I need also to do ECG scan, and CT scan. Why CT scan? Because the CT scan will show actually subarachnoid hemorrhage. It is the preliminary or the initial investigation for the CT for the subarachnoid hemorrhage, and please mark CT scan because this is the initial or suggestive investigation. In the management, you will disclose. From what you told me, or do you have any idea what's going on? What is it, doctor? From what you told me, it seems that you are having a problem we call subarachnoid hemorrhage. Have you ever heard about it? So please try to share the patient. Okay, this question I was asked about it before. Guys, in any cardiovascular problem, you will do ECG definitely. Why? Because actually the patient is having high blood pressure. The high blood pressure could, beside the subarachnoid hemorrhage, it can cause some heart problem as well. So if it causes a problem in the brain, it would more likely cause a problem in the heart. So we need to check on the heart as well, which can kill before the brain. Okay, the heart is in the C, the brain is in the D. Okay, so now you will tell the patient it is a condition in which there is a bleeding on the surface of the brain. Oh, doctor, why did it happen to me? If he asks you why, you will say that this is one of the complications of the high blood pressure, especially if uncontrolled. What are you going to do for me right now? You are going, number one, to keep the patient in the hospital. Why? Because you still need to do investigations. CT scan. If the CT scan does not show, we can do lumbar puncture. How to explain the lumbar puncture, Dr. Murad? Tell me quickly, how to tell the patient that they need to do lumbar puncture?
So to confirm the diagnosis, we need to take a tiny bit of fluid from your spine and send it to the laboratory for testing.
See, you took at least 20 seconds to say it. Why don't you simply say that I need to take a sample from the fluid around your spine?
Okay.
Very simple. Do not think about it. These things actually you will. That's why I need you to try while you are studying. Please try to explain everything in patient words. It will take you the whole script that I wrote to you right now. It will take you only 5 minutes to read. This is easier than any script you will find in the world. But I just need you to train on how to say in the patient words, please. Okay. So thank you. So now you will do CT lumbar puncture to confirm. If the diagnosis is confirmed, what you will do right now to the patient? Number one, shift to the ICU. This is an emergency and it needs many support. What you will do in the ICU, you will give painkillers for the headache and antiemetics for the nausea and vomiting. This is a symptomatic treatment that we spoke about. Number one, admission. Number two, senior review. Number three, symptomatic, which is painkiller and anti-sickness medication. What's next? You will give a medication to increase or to maintain the blood flow to the brain. Why? Because in subarachnoid hemorrhage, there's a chance of reduced blood flow to the brain. You will give also medication to prevent the seizure. You may consider doing a procedure we call clipping. What is the clipping? To get rid of the bleeding and to seize the bleeding source. So this clipping is to stop the bleeding. Okay, we are going to do a procedure to stop the bleeding. We call it clipping. After doing these 5 steps, what you're going to do to the patient, you're going to try to lower the blood pressure gradually, please. We're going to monitor and lower your blood pressure because it is a cause here. And if you ever have time, you can advise the patient about smoking. Like for example, I know that it can be hard, but you told me that you have been smoking on a higher level. So please, it would be better if you stop smoking. Have you ever thought about it? He will tell you no, or she will tell you no. Okay, it's better as I told you, so we can help you if you wish. So here again, the management, it is number one, CT scan. If confirmed, or sorry, if not conclusive, you can do lumbar puncture. If confirmed, you are going to shift to the ICU, give painkiller antiemetics and medication to stop or to prevent the reduction of blood flow to the brain, medication to prevent the seizure, and do procedure we call clipping. Why clipping? To stop the blood flow or to stop the bleeding. After finishing the initial management, we can do the further management, which is a safety netting and warning signs. What are safety netting here? We are going to lower your blood pressure gradually, and we advise you about smoking. This is the station so far. Guys, okay, this is a good question, Dr. Kashi. This is an emergency. So we spoke yesterday about this. We say that you first give the emergency treatment, and if ever you are left with few seconds in the end of the station, why don't you simply tell the patient that your blood pressure was on the higher side? So you need to attend the follow-ups regularly, and you may need to do some changes in your lifestyle. Which change, doctor? You told me that you have been smoking. So it will be better if you stop smoking. And now you can speak about smoking. But please keep this till the far end, because this is not the acute treatment. If you say that, or if you see the patient dying before your hands or having emergency and you still speak about the lifestyle, this is awkward a little bit. So this is a station so far. I like this station actually. It used to come before, but it does not, it still comes. But you know, it's not so frequent. They bring right now the Migraine Station, which we will discuss right now. Migraine Station, you pray that you get this station in the exam. It came 2 days ago. It came on Thursday, and it was a little bit twist. Why was a little bit twist? I will tell you right now. I will send you a photo of the migraine notes right now. I am sorry again if I am not posting PDF scan or PDF files these days. I'll post it from tomorrow because I still have to scan these things, and scanner is not available in the moment. So for the migraine, by the way, the task will show you vitals. I mean, in the task there is written, there is a vitals or use chart given. Sorry, there is a vitals given in the task itself. So can anyone guess about the vitals? Dr. Yasmin, can you guess about the vitals?
Hello, vitals would be normal in migraine.
Perfect.
Probably, yeah.
Thank you, Dr. Yasmin. Actually, vitals are quite normal in migraine. So now you know that the patient is having severe headache, but with normal vitals. What it could be? It could be mostly migraine or tension headache. What is the difference between the migraine and the tension headache? Simply, the tension headache, it usually comes in the end of the day, and it is intermittent, which means that it comes every day, but in the end of the day. Migraine is episodic. It comes every now and then with triggering factors. Okay? Tension headache is only related to stress. Migraine is related to many trigger factors. What are the triggering factors of migraine? Okay, let's speak about the triggering factors of migraine. Number 1, stress. Number 2, flashing lights. Number 3, loud noise. Number 4, cheese and chocolate and tea. So there are many triggers. You will simply ask the patient what could bring this headache. He will tell you, doctor, it comes with loud noise. Doctor, it comes with this and this. So I sent it to the WhatsApp group right now, the migraine. I wrote you in high case the news chart. You know what? After looking at the news chart, you will get to know that this station is migraine. Definitely. Why you will know that this is migraine? Because the news chart shows very normal vitals. Still, when you enter, you'll find the patient in severe headache. So normal vitals with severe headache is usually migraine. The tension headache is not this severe. Moreover, the setting here is A&E. In tension headache, it's mostly GP. So migraine mostly A&E, tension headache is mostly GP because she is not in pain now. In tension headache, the patient is not in pain now. But in migraine, the patient is in pain now and severe pain. Okay? Okay. So you will read the notes that I posted right now on WhatsApp group. You read that the headache, you will elaborate the headache. You will find that it is one-sided headache, only in one side, and it came 2 or 3 days ago. It was intermittent in the beginning, but now it's continuous. And it was coming with noise and loud voices. So let's try to elaborate the headache here. Tell me more about this headache. When did it start? How did it start? Has it changed? Yes, doctor, it was intermittent in the beginning, but right now it became continuous, and it's getting even worse. Anything makes it better? Try paracetamol. Anything made it worse? No, doctor, but I noticed that it came with noise and loud voices. It gets worse with this. Okay. Does it go anywhere else? Did it start anywhere else? Can you describe the pain for me? Can you score the pain for me on a scale from 1 to 10? 1 being the lowest and 10 being the highest? This is the elaboration of the pain. I just gave you the positive findings. What are the associating symptoms for any headache, guys? We agree that the associating symptoms of headache are number 1. By the way, there's one thing I need to mention here. Sometimes the patient may show you that she is bothered by the light. What will you do if the patient is bothered with the light, Dr. Samia? Dr. Samia, what if the patient is bothered with the light? Dr. Samia is not here. Okay, so if the patient is bothered with the light, you know what to do. Here in this case, you will say, would you like me to dim the light? You will say, yes, doctor. The examiner will tell you, assume. So please add in the notes that sometimes the patient can be having photophobia. And they will try to show it to you. No problem, Dr. Samia. So the patient will show you that she is having photophobia. What you will do, you will dim the light. Assume, doctor. Okay. What are the associating symptoms for any headache? As we agreed before, nausea, vomiting. Okay, Dr. Safa, no problem. So nausea, vomiting, blurred vision, or visual loss. You can also ask about numbness or weakness. The thing that I'm writing like check mark after them, they are mostly present in this station. But the wrong, it means that this finding is not present, but just you have to ask about them. So the associating symptoms for any headache and photophobia, you will ask about number 1, nausea and vomiting, number 2, blurred vision, number 3, visual loss, number 4, numbness. Ask these questions in any headache station. Those are the most red flags which can be related to headache. What are your DDs? The DDs here are, again, GCA, subarachnoid hemorrhage, meningitis, and cluster headache, similar to meningitis station. How to ask about GCA, any jaw pain. How to ask about SAH. Simply, you'll ask about any neck stiffness, any shyness to the light. How to ask about meningitis. You'll ask about fever or rash. So fever or rash, neck stiffness or weakness, or shyness to the light. She's already giving you photophobia, so no need to ask about it again. GCA, jaw pain. And full cluster headache, I wrote to you that you need to ask if there is any swelling of the lid. This is the jaw pain. So simply for the headache, you'll ask 3 associating symptoms and 3 DDs. So the headache, please keep it 3 and 3. 3 associating and 3 DDs. 3 associating and 3 DDs. This is what I need from you in any headache station. Ask in the past medical history, you'll find that the patient was having previous episodes of headache, but they were never like this episode. This means that this episode is harder than any previous episode. Okay, so you will ask her if she was diagnosed with migraine or not in the medical conditions, if she is having any high blood pressure or not. And if she was having, please add also in the past medical history that you need to ask about any fever or flu-like illness. Dr. Rumi, do you know why we are asking about any fever or flu-like illness here?
Could you please ask the question again?
Oh, someone is not concentrating. Okay, Dr. Rumi, do you know why we ask about any fever or flu-like illness here?
Fever.
Oh.
To rule out meningitis.
Perfect. Not only meningitis, but actually, you know, if in the recent days there was flu, it could be leading to either meningitis or it could be even one trigger of the migraine. The infections, especially the feverish and the flu-like symptoms, they can sometimes trigger the migraine as well. Okay, so please add that you need to ask about any flu-like illness in the past few days. Okay? Okay. So now we'll also ask about any family history of migraine. Those are the relevant questions in the past medical history. Now, small quiz. I need someone to come, please open the microphone and show me how to ask about the past medical history. Dr. Fumbi, welcome today. I need you to ask me how to ask about the past medical history of the patient. Any past medical history of the patient, how to ask about it. And please do it quickly. You have less than 1 minute.
Okay, hello.
Hello.
Can you hear me?
Yeah, sure.
I'll just go. I'm going to be asking you a few questions about your um past medical health, if it's okay with you.
Yeah, okay.
How has your health been generally?
Doctor, my health has been fine.
Oh, great. By chance, is there any history of high blood pressure in your family?
Dr. Fumbi, did that what we agree about? Didn't we agree that you have to ask number one, did you have similar episodes in the past? Number two, how was, okay, you can turn off the mic right now. I will elaborate it one more time.
Okay, I guess I missed that part, yes.
Yeah, no problem. Okay, so in the past medical history, you ask number one, have you had any similar episodes in the past? Number two, how was your health recently? In the recent health, you can ask about any fever or flu-like illness in the past few days. Number three, do you have any medical condition? They will tell you, usually they will tell you, no, doctor. Any high blood pressure? Any high blood sugar? Any high cholesterol? No. Number four, do you take any medications, including over-the-counter or painkillers? Number five, do you have any allergy to any food or drugs? Number six, have you ever been hospitalized before? Number seven, did you have any surgery before? Number eight, any family history of any medical condition? Any family history of similar complaint? So ask about any family history of any medical condition at the beginning. After that, any family history of any similar complaint or similar problem. Okay, now you can ask about the lifestyle. After that, before moving to the lifestyle, I'm going to ask you a few questions regarding your lifestyle. So do you smoke? Ask about the lifestyle here in details. I'm writing in the notes that you have to ask in details. You know why? Because some things in the diet can precipitate the migraine attack, like the cheese and the chocolate and the tea and the coffee. So do you drink tea and coffee too much? What about any cheese or chocolate? Do you think that they bring up your pain? Okay. You can also ask about the physical activity, because strenuous physical activity sometimes can precipitate these attacks. You can also ask about smoking and alcohol. So please ask in details about the lifestyle here, including the job. Job actually is social history, but we need to ask it after the lifestyle directly. Why? I will tell you why. Because actually the job is stressful here. Here job is stressful. And stress is one of the triggers of the migraine. But please do not confuse it with the tension headache. Because in the tension headache, I will tell you right now, the tension headache, guys, the tension headache actually, she will give you also stress in the job. But always remember that this is migraine. You already knew that this is migraine. It came many times before and it disappeared. But in the tension headache, it is there since many days. It doesn't go away. And it only comes in the end of the day. And she is not in pain right now, in the tension headache. But in migraine, she's giving you bad pain right now. I told you that here I wrote in the notes, do not forget the 4-piece, because she is female. Okay? Okay. Now here, the task, by the way, will tell you do not examine the patient. So you are not supposed to mention the examinations at all. Move to the management. You will tell the patient that it seems to me that you're having a condition we call 4-piece, Dr. Murad. 4-piece again. I wrote it to you yesterday, by the way, guys. Let's confirm that. The 4-piece simply are period, pregnancy, pills, and pap smear. Period, pregnancy, pills, and pap smear. Okay? Okay. So this question actually was asked to me like twice today. So if I was not clear about it yesterday, I'm sorry. But I think I explained it yesterday. I explained it, but I did not include it in the notes. So thank you for reminding me. I will include it today. So now we will ask about, we will tell what's migraine. So you're having migraine. Doctor, what's migraine? She will tell you, or he will tell her, it is an episodic or attacks of headache associated with nausea and vomiting. between them, you are absolutely fine. So it is attacks between which you are absolutely fine. Now, I wrote the management in terms of viewpoints. Why? Because if I give you many answers or long paragraphs, you will be hating yourself. So the concern here, doctor, is it brain cancer? What will you say, Dr. Bina? Dr. Bina, what will you say if I tell you, doctor, is it brain cancer? What will
May I know your concern?
Perfect, Dr. Bina. Thank you. You can mute yourself. So, may I know why you think so? She will tell you, doctor, because one of my friends, doctor, she was having a very bad headache and she was diagnosed with brain cancer. So now, what will you say? You will tell her that, please write it in your notes. By the way, I do not write everything in the notes for two reasons. Number one, I need you to concentrate while I'm speaking so that you can write by yourself. Number two, I do not need them to be lengthy so that you will not hate the view of the notes. So it is not brain cancer. Tell her that I can see that you are quite worried, but let me assure you that from what you told me, you do not have any symptoms suggestive of brain cancer. This is usually a common condition and it's known as migraine. Okay, so she does not have any symptoms suggestive of brain cancer. Doctor, aren't you going to do CT scan for me? May I know why? Doctor, because it could be cancer. Doctor, I need to find out the reason of my headache, please. I wrote you in the note that there are 3 reasons not to do CT scan. Number 1, the cause is known, which is migraine. Number 2, doing CT scan will expose her to many radiations. And it is a long deal or long trip. So she will be in trouble if she is exposed to many radiations. Number 3, the picture of the CT scan will not reveal anything. So she may need to do further investigations to find out the real cause. So it is a long journey. So I'm sure you do not want all this to happen to you. So number 1, it is a common condition and it's nothing bad, it's called migraine. Number 2, CT scan is many radiation and you do not want yourself to be exposed to such radiation. Number 3 as well is that the picture is never clear. I mean, it will not give you a reason or it will not show anything. Okay, so you will may need further tests or further scans. And usually no of the scans or none of the scans will show anything. Okay, however, if you are worried, we may send you to your GP. He will further assist you and he can order CT scan for you and if needed in a while. But for now, you do not need CT scan. What will be the treatment? The treatment of the migraine is simply, number 1, symptomatic treatment. You will give her right now painkillers and anti-sickness medication because she gave you pain and nausea and vomiting. Remember? Number 1, symptomatic. By the way, is there any need to admit this patient here? Anyone think that we can need to admit the patient here? Dr. Lamia thinks that we should not admit the patient. Dr. Lamia, why we should not admit the patient?
Hello, because
Yeah.
it's a common condition and just need painkillers and reassurance because it does not need any investigations or something.
Okay, perfect. So you do not need to give any painkillers for 2 reasons. Number 1, it is a known condition, and it's it's very known condition called migraine. Number 2, actually her vitals are quite normal. Her state, you already knew her state. She gave you detailed history of triggering factors and headache which comes in episodes by these triggers. So you do not need to admit her or do anything. Her vitals are quite normal and she is stable vitally. So you do not need to admit her at all. So what are you going to do? Number 1, symptomatic treatment. Number 2, you can tell her that your GP will prescribe some prophylactic medications which can prevent the attacks of headache in the future. We call them triptan. So simply say medications to prevent further attacks, and you may need to take them regularly. Okay, number 3, we'll advise here about some lifestyle changes. What could be the lifestyle changes in the migraine? Let's speak about them. Number 1, if she takes much chocolate and tea and coffee, try to avoid it. Try to avoid the loud noise and loud music, which can precipitate her attacks. Stress, tries to chill. Try to do some meditation, which can help her feel ease. And then sleep, have proper sleep. Okay? So just, you will pick up the triggering factors which she told you in the history, and you will address it in the management. Sometimes in severe cases, we can prescribe anti-epileptic or anti-seizure medications in the cases which are not responding to the triptan nor the usual painkillers. Do not bring it on. I mean, do not say it. Just for your knowledge, we can prescribe anti-seizures in the resistant cases. Then you'll advise her, no senior review, Dr. Zaid. Senior review actually is for the emergency cases or the suspected cases or doubtful. But here you are quite sure this is migraine. Okay? Okay. You will advise her about something we call migraine diary. You know, guys, in any disease which is having triggering factors like the asthma, like the epilepsy, like whatever, you will provide a diary. It will be provided by a GP. This diary will show how many episodes she got and the timing of the episodes and the triggering factors to these episodes and how they were managed, these episodes. So number one, number of episodes, timing of these episodes, triggering factors of the episodes, and how they were managed. Okay? She will follow up, or she uses the diary to follow up with the GP. Last thing is the warning signs. What could be the warning signs in the case of migraine, Dr. Zaid? Dr. Zaid, what could be the warning signs?
Hello.
Yeah.
If you developed severe sudden headache or neck pain, please dial 999.
Perfect. And I can add also one thing is that if you develop any maybe slurred speech or any weakness in one of your side of the body, you know why? If you know why, I will give you I will send you £5 to your account. Seriously, I'm not kidding.
No, I'm sorry again.
No, if you know why we should warn the patient about the slurred speech and the weakness, I mean, we should also we should warn the patient about them.
Yeah, because of the migraine is a risk factor for stroke.
What? Excuse me?
Is it a risk factor for stroke?
Why?
Because I think one of the, this is one theoretically. This is one of the type of the migraine is called migraine with I don't know with symptoms like just like stroke. So we're afraid from stroke or bleeding.
Well, you were close. You were close. You were close anyway. Listen, usually the migraine is presented with aura. This patient told you that she's having flashing lights before, and sometimes she sees zigzag lines. You know what this means? The patients who are having migraine are more likely to develop stroke.
Right.
Sorry, the patients who are having aura. This aura, you know what is this aura? This aura is a temporary disruption of the blood supply, temporary disruption, which will put her at high risk for TIA and stroke. So if she's having aura, she may likely have a stroke. So in the warning signs, you will tell her the warning signs of the stroke, which are facial weakness or any slurred speech or any weakness on one side of the body. I hope this was clear enough. Yes, fast, exactly. Fast, which stands for facial weakness, arm weakness, and slurred speech. And T, what was the T? I think it was, I don't remember the T. What was the T?
Timing.
Timing, yes, more than 1 hour. Okay, so here in this case, just warn her about the stroke. Okay. Was this station clear, guys? This station, by the way, it's a very nice station. Many people fail it. You know why they fail it? Because still many people are not able to pick up if this was subarachnoid or if it was GCA or if it was like whatever, if it was like of the DDs. I hope everyone here now know the difference between the three stages. Let's have a quick sum up with them right now. Subarachnoid hemorrhage, most importantly, hypertension, and meningitis, fever. Migraine is normal vitals. Let's speak about the tension headache. In the tension headache station, actually it is a shame if I elaborate it in details. Why? Because most of us are having tension headache. Not most of us. I think all of us. We have been preparing for PLAB 2 for months. We have been also preparing for many medical exams for months in which we are bending our neck downward, in which we are feeling very good frontal headache in the days. And we are also stressed all the time. That's why you are giving tension headache, right? So in the tension headache station, it is quite similar to the migraine, but with few differences. Number one is that you are in GP, but this doesn't mean that the migraine can come to you in GP. Okay, no problem, Dr. Murad. You can take your time. So, by the way, this station can also come in GP. Can you excuse me for a minute, guys? I'm sorry. Excuse me for a minute. Sorry guys, I'm back. So in the tension headache, the only difference is that, or the few differences are, number one, you are in GP. Number two, having said that, this does not mean that the migraine cannot come in GP. Actually, it can come in GP as well. But the important thing to know is that here, usually the migraine will come in E&E because they need to stress you out. The GMC needs to stress you. They need to see if you are able to pick the difference between the migraine and the meningitis and subarachnoid hemorrhage and tension headache. So usually the patient is in GP or in the migraine. Sorry, the patient is in A&E in the migraine, but in the tension headache it is in GP. I sent you right now the notes on the group. The differences are: number one, you are in GP. Number two, headache is in forehead. In the migraine, you know, it's usually in one side of the head, usually the temporal side. And it comes in the end of the day here in the tension headache. In the migraine, it is episodes which can come at any time. Okay, the patient will give you history of recent change in the job. By the way, in the migraine, she can give you this as well. So please mark this as a common finding in both stations. You know that stress is trigger factor of the migraine as well. But in the tension headache, it is the cause of tension headache. Not just triggering factor, no, it is the cause of tension headache. And the big difference is that the patient is not in pain right now. But in migraine, she is in pain. She is actually rolling of pain. Now, I wrote you the examination and I wrote an alarm beside it. Which examination you need to do? Can anyone elaborate which examinations we need to do in this case? Dr. Ella? Dr. Ella, can you tell me which examination?
We need to do Will be just general physical examination and neurological examination.
Perfect. Which neurological examination?
We are going to do the same way as we did in migraine.
Dr. Ella, I will kill you right now.
Be asking.
I will kill you right now,
please
Dr.
don't, please don't do that.
Dr. Ella, I told you, wait.
Yes.
I told you that in the Migraine Station, the task tells you do not examine the patient.
Yes, yeah. But here we are going, no. In meningitis, I'm sorry,
Yes,
I meant
exactly.
meningitis.
Okay,
it was in my head, but my mouth was separately.
No problem. Tell me which examination?
So we are going to do GCS. We are going to do with the neck, with the Brudzinski, and with the other one, and also that's it.
Okay, perfect. Very enough.
That's it. Yeah.
Yes, this is very enough.
Yeah. Thank you.
You're welcome. So these examinations you will do, I mean, beside the vitals and general physical examination, you will do these examinations which we just mentioned right now. Dr. Ella.
Yes, yeah.
Okay.
Yes, yeah.
Thank you. You can mute yourself right now.
Thank
so right
you.
now, you will do some investigations. Which investigations? You only do routine blood tests because you're in GP. Routine bloods are very enough. Like full blood count, kidney and liver function test, and maybe thyroid function test as well. These are not important because you already know that the diagnosis here from the history is tension headache. Why tension headache? Because the headache comes, the headache actually it comes on the end of the day only. This is number one. Number two as well, the headache is intermittent. I mean, it comes and goes, but it is there since 15 days. That's why she came to the GP clinic. And one thing, the headache is worsened by stress at the end of the day. You already know. What are the associating symptoms to any headache? I told you, nausea, vomiting, any blurry vision, any problem with the vision generally. What are your DDs here? Your DDs here should be GCA, meningitis, and SOL. Remember, headache, 3 associating and 3 DDs. 3 associating and 3 DDs. What is the management? You will tell the patient it seems to me that you're having a condition we call tension headache. Pause. Whoever will practice with me and they will not pause, seriously, okay, the patient or the person who will not pause will pay a fine of £5 for each not pause. Because this is not, like, this is serious. This is urgent. I do not need anyone to not pause, okay? So, tension headache simply is a sort of headache, which is chronic headache, like prolonged headache, okay? Which comes usually due to some tension, which could be some physical tension due to some like stress in the neck muscles or spasm in the neck muscles for a prolonged period. Could be also psychological tension, like the stress that you're having due to change in the jobs. Why did I get a doctor? Because of jobs change and because of neck problem or neck pain. You know, usually if someone is having prolonged neck pain, they will end up having headache, which we call tension headache. Sometimes also it runs in family. If her father or mother are having this condition, she will likely to develop it. Okay. She will ask you the same question as migraine. She will ask you, doctor, can you do CT scan for me? What will you answer, Dr. Kachi? Dr. Kachi. Dr. Kachi.
Hello?
Yeah.
Hello?
Yeah, tell me.
Okay, I will ask him, may I know why?
Perfect, Dr. Kachi. Doctor, because I think it could be like something serious, doctor. I need to find out the reason of the headache.
Okay. Well, from what you told me, everything points out that you don't have the headache is not a life-threatening.
Mm-hmm. Okay. So why not CT scan?
Okay, because from your history and for what you told me so far, is not life-threatening. And doing a CT scan will expose you to radiation,
Perfect.
which I know you will not want.
Yeah, and the image will not be clear. So you will need further investigations to find out the reason, and it is a big deal, or it is a big, like when you say big trip, which you do not want.
Yes.
Okay. Okay.
Okay.
However, your GP, sorry, she's in GP. However, if you are concerned, or if you develop any of the symptoms, like maybe if you develop any weakness or slurred speech, we can do CT scan for you. This will be the warning signs. Okay, no problem. So generally the CT scan, we will not do it. See guys, in the notes, I pointed out 3 R's besides CT scan. 3 reasons. Number 1, it is unlikely to be serious. Number 2, CT scan will not show anything. Number 3 as well, that the image will not be clear. So you may need further investigations, and it is a big deal. Why? She will ask you, doctor, is it cancer? May I know why you think so? Because one of my friends had the same answer as migraine. No symptoms suggestive of cancer. Okay, this is a very common condition we call tension headache. What is the treatment of the tension headache? Treatment of the tension headache, it's called tension, which means that she needs some lifestyle changes. If someone is having any tension headache, we advise usually what? Number one, very important. Try to have rest or break from your job, because this is the reason of her tension headache. So we will advise her about the posture, to have break from her job. Number 2, we'll advise her to change her position every now and then, because she will tell you that she is doing an office job. So she needs some break in the middle. So try to change your position. Do not fix your position for a long time. Okay? This is one thing as well. When she is sleeping in the bed, please do not sleep over 2 or more pillows, because sleeping over more than 1 pillow may cause her some neck pain, and the neck pain brings the tension headache. Also advise her about smoking, and advise her about stress. Why stress? Because stress is the reason for her tension headache. How to deal with stress? You'll advise her about some meditation like yoga, like swimming, like walking. If she cannot cope with the stress, she can speak to the occupational health department, or she can be offered some counseling sessions to show how to deal with the stress. So again, number 1, smoking. Number 2, changing position. Number 3, take a break from your work. Number 4, stress. Number 5, the pillow. Okay. Also, if possible, try to avoid or try to not drink too much tea and coffee. Okay. Okay. Then you will tell her about the painkillers. We can give you some painkillers like paracetamol. What if she told you that the paracetamol did not help her? You will tell her that we can prescribe you some stronger painkillers. However, we do not suggest them unless you try the lifestyle and the simple painkillers in the beginning, because you are as well having some side effects. It's like any station. We usually start with simple painkillers and lifestyle. If they do not work, we can prescribe stronger painkillers in the next. Okay, this is a good question. If the headache continues, we can consider CT. Yes, you can say so. But you will assure her that most probably the headache here is tension headache. So no need to do CT scan at all. However, if it continues for long, even after the measures that we're going to tell you, and if it's really bothering you, we may need to do CT scan, or we may consider CT scan for you. So you are telling her that we can consider it very later, not now at all, or not at the moment at all. Okay? This station, you pray that you get it. This is a very nice lady, and it is very cooperative. She is not in pain. She's just here to discuss this. I consider this station is just a counseling station. I do not consider it history taking, but anyway, it is history taking because the diagnosis is not known yet. You have to diagnose tension headache. Okay. One thing as well, doctor, the one who will ask this question actually, okay, I do not want to offer rewards from now, because if I offer rewards from now, I'm sure that I will end up the course being broke. So, doctor, let's pick on someone. Dr. Manisha, I haven't heard your voice before. So, Dr. Manisha, tell me, are you here?
Hello, I'm here.
Nice to meet you, Dr. Manisha.
Echo.
There is an echo. There is an echo.
How is it?
Okay, so Dr. Manisha, tell me quickly, which question you may need to ask this patient. Okay, let me like give you a quick tip. This patient is having prolonged headache since maybe 1 month, which comes in the end of the day after a stressful, long, tiring day. What will be the questions that you may ask this patient, and it will be very helpful to you and will let the patient speak too much?
So we'll be asking about the stress.
Okay, that's good. But what's your question? You can ask simply, very simple question. I can ask the patient, and the patient can speak too much to answer it. And you will usually ask it in the end of your data gathering.
Okay, so how is it affecting your daily life?
Perfect, Dr. Manish. Perfect. Seriously. Thank you. If you ask this question to the patient, actually the patient will tell you, doctor, I'm really tired in the evening. I cannot do my house chores. I cannot take my children out. I can't, like this. By the way, you know now how it has affected your life. So we will address this in the management by giving the lifestyle advices. Thank you, Dr. Manish, really. You have proven good wills. Dr. Zaid, tell me why you feel it.
Well, probably, yes, the radio was very nice. And as you said, and honestly, I ask every question. I dealt with her just like the GP. I'd ask her about the sleep. How's your sleeping? How's your mood? How is your I was filing the questions. So I wasn't follow structure of my mind. And then I didn't reach even to a diagnosis. I told her, well, this one. She told me that she has a neck pain, and hello, yes, yeah. And she told me that it's affecting her sleep, and so I honestly, I get confused in the station. So I told her this is. I don't know, because I didn't reach to the final diagnosis in this case. Yeah, frankly.
So I hope right now that you could reach your point. I mean, did you know, Dr. J, did you really understand it right now? I mean, did you understand the station, how it works right now?
Right. Thank you.
No, tell me honestly, did you get the station right now or not yet?
Yeah, I get the station. because I was following in my mind's other structure, other form of questioning. So with this approach, I think it will be better. Yeah. The approach of the.
Yeah. So here you know now how to take history, guys. And by the way, I decided something. Every day after each session, I will pick up someone to practice with me. After each session, like every day session, one station. And today I will start with Dr. Zaid. And you will practice with me the tension headache to Dr. Zaid. No, not tension headache. I will not give you the diagnosis for the station. And you will pick up copy yourself. Okay? So you will practice with me after the session today, inshallah. And I will put a schedule for everyone. And by the way, in the end of the session, I need to tell you some few tips in less than 10 minutes. Because you guys will be practicing together.
Right.
Yes, definitely, Dr. Murad, if the patient tells you any complaint, do not overlook it. If you overlook any complaint, you are in trouble. I mean, if you do not ask about visual loss and numbness and such things, oh, maybe you forgot about them. It's fine. But if the patient tells you something and you do not elaborate it, you are in trouble. Okay? Do not overlook anything the patient tells you. If you overlook, you are in trouble and you may even not get a good mark in data gathering. Okay. So now we spoke about everything in this station. One tip, guys, before I forget. Okay, Dr. Munipa. The inverted lamp in my notes, Dr. Munipa, is a very good question, actually. Inverted lamp is the alert. The alert, which means that take care of this thing. Take care of this thing. Why? Because many people forget the examination in the tension headache. Because it's usually easy station. Many people take it for granted, so they forget to examine the patient. So please, you will write it yourself, and you will write that we have to stress on the examination. Okay? Do not ever forget about this alert. At least I hope it will remind you in your exam. Okay, guys, so let's move to one interesting station, which is the GCA. I meant to include it right now, the GCA station. Why did I include it? But before proceeding, Dr. Mahdi, are you concentrating? Dr. Mahdi? Dr. Mahdi is not concentrating, which means that he is more liable to pay a fine, and his wife will pay the fine for him. Okay, so the GCA is a very nice station, but it has two scenarios. One scenario is history-based scenario, and one other scenario is combined station, which means that you need to do some examinations. I will explain the combined station because the history-based station does not come anymore. It comes as a combined station nowadays, like in which you need to do examinations. Okay? Okay. So the presenting complaint here is headache and visual loss. The patient will give you, doctor, I'm having visual loss, or I cannot see with my, for example, right eye. I'm so sorry to hear that. Okay, how to elaborate the visual loss? Visual loss simply will ask since when it starts. Before since when? Ask the patient differently. Tell me more about it. What do you need to know, doctor? Number one, which eye? Number two, when did it start? Number three, you can ask the patient if it's complete or partial. Why? Because it differs. It will differ in the management. So you will ask the patient, you can't see at all, or it's simply like visual problem. She will tell you, doctor, accordingly, it can differ from one patient to another. Okay, so number one, the side. Number two, when it started. Number three, complete or partial. Has it changed? No. Very simple, 4 questions. Then elaborate the headache. You will find that the visual loss usually is sudden visual loss which started few days ago. Sorry, a few hours ago, like 3 or 4 hours ago. I will take a photo for it right now and I will send it to you guys. Then the headache, you will elaborate the headache. And usually the headache will be starting together with the visual loss or slightly after the visual loss. Okay? Okay. One important thing I need you to all remember is that this headache here, if you are suspecting GCA through the visual loss, you need to ask the patient about the radiation of the headache. Radiation is a very important question in GCA station. Why? Because the headache is usually radiated to the jaw pain, to the jaw. Dr. Ella, can you hear me? Dr. Ella? Dr. Ella, I think you can hear me. Dr. Ella? Dr. Ella, you can speak. I think you're attending. You do not have any problem. Am I clear, guys? My voice is clear? Please, everyone answer me.
Yes, 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 yes.
Okay. So, I think the problem was with Dr. Ella microphone. Okay. So, you are going to ask the patient about if it's radiating to the jaw or not. Why? This question is very important when you are suspecting GCA. How to suspect GCA? Usually it is painful visual loss. Did you get it? The patient usually is having headache, but painful, not eye pain. It is like having headache. Okay, so headache with visual loss points you most probably toward GCA. No, you can hear right now. Dr. Ella, I think there's a problem in your headphones. Okay, so after elaborating the headache, you will usually find jaw pain. Elaborate the jaw pain. Like when did it start? How did it start? Or the patient may tell you simply, doctor, the headache just goes to my jaw. So it's just a radiation. You do not need to elaborate it. So headache, elaborate the headache, elaborate the visual loss, and elaborate the jaw pain. Usually, they will give you also nausea and vomiting. I will post it to you right now on the WhatsApp group. Please mind it. Have a quick look at this station in the script. Okay. What will be the associating symptoms? As we agreed, associating symptoms to any headache: fever, photophobia, rash. Fever, photophobia, rash. Or you can keep them in the differentials as well. I don't have any problem because they will be asked in the DDs. You can here let the associating symptoms be, like, for example, any weakness. Okay. You can also ask about any numbness, guys. This is very enough. The thing is that if you are suspecting GCA, there is a close association between the GCA and depression and hypothyroidism. So you can also ask one question. For example, do you feel cold when people around you feel okay with the weather? And how is your mood? Mind that this is a combined station in which you still need to do examination. So if you do not ask these questions like the associating symptoms, it's fine. Do not ask too much history in these stations. Like pick up the present and complain, rule out the DDs. What are the differentials here? Number 1, meningitis. Number 2, migraine. Number 3, SAH. Number 4, SOL. Please, I need all of you to write in the blank, I mean, on top of these points, I need you to write that make your history as concise as possible, which means you need to ask one question only for each differential. Because this is still, you need to do some examinations. Okay? Okay. Okay. So now I ruled out DDs. Dr. Ella, I think you are on right now, Dr. Ella. Can you hear me, Dr. Ella? So right now, I'm going to ask the past medical history. In the past medical history, pick up only 2 things. Number 1, hypertension and cholesterol in the medical conditions. Number 2, the family history, because it runs in families. I do not tell you to not ask about other questions. No, ask about them, but do not go deep. Like, for example, do not ask you can ask about the medications, but do not ask any previous surgery or hospitalization because it's irrelevant here. Okay, so I mean, try to filter your past medical history as much as possible, especially in the examination stations. Okay, lifestyle, please ask about smoking. Very important. The smoking only is important here. So right here in the lifestyle, smoking only. Then always remember, this is female patient. So we need to ask about the 4 Ps. If someone forgets to ask me about 4 Ps when we are practicing, again, £5 fine. Because I'm counting, some people may think that I'm kidding. No, I'm not kidding. Actually, I'm making a list of the fees that the people have to make as a fine. For example, I was starting with Dr. Masih, and I canceled him because he gave me a good answer after that. Dr. Masih, who thinks that his exam is the day after tomorrow, inshallah. But I appreciate that he asked me a very good question. 4 Ps here. Dr. Murad, I think you're sleeping. She is a female patient. Female patient, you need to ask 4 Ps. You know why? At least the pills. Ask the pills. Why? Because GCA is still sometimes, you know, it's autoimmune condition, and sometimes it can be worsened by using pills. Okay, temporal arthritis. Temporal arthritis, any vascular disease, any autoimmune disease, ask this question about the 4 Ps. Just ask about the pills. Pills are very enough. Here, just ask this question. Why asking this question? Because she is a female patient. At least ask this question. Do you take any pills? Why I write the 4 Ps? Because I do not want you to filter them. I need you only to remember them in each female patient. Now move to the examination. Please have a look at the steps of the examination. I wrote it to you right now. I wrote them to you with a quick hint of how to do them. Number one, before doing the examination, you have to rule out the glaucoma. Why? Because if the patient is having glaucoma and you are going to do the eye examination in which you shine light into them, this is like inhumane. And by the way, the glaucoma will hinder any light entry to the eye. It will prevent that. So please rule out glaucoma before the eye examination. How to rule out glaucoma? Did you see any halos around the light? Do you have any pain in the back of your eyes? No. You can rule it, by the way, before proceeding to the examination. I mean just before the examination, not necessarily in the history. Now do inspection. Look at the eye. You will inspect, and by the way, we will speak about this in details in the examination class. You will explore the eye for any discharge or any redness or swelling. Move to the red reflex. In the red reflex, I'm going to shine a bright light into your eyes. Okay, for that, I'm going to dim the light. I wrote you dim the light between two brackets. Why? Because most of the people forget to dim the light. You will dim the light and you will do the red reflex on both sides. Number 3, Thunduscopy. Now I'm going to come closer with this bright light into your eyes. So please bear with me. Usually you will do the Thunduscopy on the mannequin. Before doing the Thunduscopy, turn off the light of the fundoscope. Why you will turn off the light? Because there is a light coming from the back of the mannequin. So if two lights meet together, there will be no picture, or the picture will not be clear. So it's better if you dim the light of the fundoscope. Just say, I can see there is light coming from the back of the mannequin, so I need to dim the light right now. What will be the comment in the fundoscope? I can see the optic disc. Optic disc is pinkish yellowish in color. Optic disc to cup ratio is normal. Macula seems to be healthy. The blood vessels are normal in caliber, not dilated nor tortuous. So this comment we will speak about later. Just make sure that you watch the Aspire videos in the examinations. Actually, they are quite good. Okay, now move to the management. Disclose to the patient that you are having a condition we call temporal arthritis or giant cell arthritis. What is this, doctor? Simply temporal arthritis. It is inflammation in the artery in the side of the head, which is a temporal artery. Why did I have it? It is an autoimmune condition. If the patient asks you what's autoimmune condition, he will simply say that our immunity, instead of fighting against the bugs, something goes wrong and it fights against our own tissue. Why do you call it giant cell, doctor? Because the cells, the inflammatory cells which occur due to this attack are called giant cells. So we call it upon the cells which accumulate in the vessel. Okay, what are you going to do for me, doctor? Number 1, admission. Why admission? She's presented with visual loss. You need to admit her right now. You will ask the senior to come and review her. Meanwhile, you will order ESR and CRP as initial inflammatory markers and give painkillers and anti-sickness, symptomatic. So number 1, admission. Number 2, senior review. Number 3, symptomatic, which is painkiller and anti-sickness medication. Number 4, you will give high-dose steroids, which is a definitive. Definitive here is high-dose steroid right now. You will start it. You will start with a high dose of steroids. After the high dose of the steroids, you will refer her to the specialist. Why? Because the specialist will do temporal biopsy. Doctor, what is this? It is a sample taken from the artery inside of your head. Doctor, is it painful? We are going to numb the area in front of your hairline. Okay, doctor. This sample is to confirm that this is the giant cell arthritis. What happens after the sample? She will usually continue on steroids for longer time. After some time, we'll taper the dose or we'll lower the dose gradually till we withdraw it. She is taking steroids. She will ask you, doctor, do they have any side effects? You will tell her, may I know what's your concern? Because you know the steroids are having many side effects. So it's better to ask her, may I know what's your concern? She is usually concerned about the osteoporosis. the bone thinning. So you will tell her that it can cause this as well, but we are going to give you proper lifestyle or proper diet advice together with calcium and vitamin D supplements. What else, doctor? You are going to give her proton pump inhibitors and mini aspirin. Proton pump inhibitors because of the peptic ulcer. Mini aspirin is to prevent any blood clots, because this condition is associated with like maybe some blood clots in the body. I mean, sorry, that corticosteroids increase the risk of blood clotting. So you need to give mini aspirin. Doctor, am I going to go blind? This question is quite a good question. Usually the patient is having visual loss. You know, the patient is presented, maybe she's presented with total visual loss. So you will tell her that I can see that you're quite worried. The thing is that actually, once the visual loss is established, it's harder to treat it. However, we can prevent the progression. I mean, here you can prevent the progression only. Once the visual loss occurs, you can prevent only the progression. You cannot cure the visual loss, you can only prevent the progression. And the good thing is that you came to us immediately. So we will start your treatment right now. The earlier the treatment, the less chance of progression. Okay? Okay. This is the station so far. This station, you can get 11 in it very easily. The outlook here, see, number 8 is outlook. Outlook means prognosis. She will ask you this question. I mean, the outlook is asked by the patient as, doctor, will I go blind? So you will answer it as I told you. It can be like permanent if it's established. However, the good thing is that you came to us early. We will start your treatment immediately and hopefully everything will be fine. Okay. If someone is having problem with reading the notes, just do let me know. Okay? If anyone is having any problem with the notes, guys, please do let me know when you are reading. Okay?
So
right
just
now,
a question.
Yeah.
For this station, GCA, the investigation will be number 3. So after the examination, DSR and CRP, right?
You do not need to do it. Okay, you will just verbalize the investigations, but the examiner will keep quiet.
Oh, yeah.
Because now from the examination, you know, guys, here the fundus is quite normal. There is no problem in the eye examination. Why? Because this is visual loss. The visual loss here is not related to the eye. It is related to the blood vessels supplying the eye. So here you will find the eye examination quite normal. So visual loss with normal eye examination, this means GCA. And now you know probably that this is GCA. Okay, so no need to do investigations here. After the examinations here, you already know that this is GCA. But just verbalize, I need to do some investigations. The examiner will not ask you. That's what we agreed about yesterday. If the examiner keeps quiet, you can move to the management directly. Okay, let's move to one station quickly. Before this station, just give me 1 minute. I'm going to come back. Dr. Murad, yes, the patient does come with visual loss. In some cases, the patient will be presented with only headache. And this scenario was old scenario. But usually the patient will come for visual loss because this is combined station which you need to do examination of the eye. Yes, Dr. Murad again, you will. The management will be, number 1, admission and senior review. Number 2, just check the notes that I just sent. You will find the whole plan of management. So, number 1, admission and senior review. Number 2, painkiller and anti-sickness medication together with ESR and CRP. Number 3 or number 4 is you will start high dose steroids right now. No, Dr. Murad, please, I need you to listen carefully what I'm saying right now. Okay? I'm just telling you again. Painkiller and anti-sickness medication. Okay? After that, you will start high dose steroids. High dose steroids, you will reduce them gradually. But I mean, you will just start high dose steroids right now. After starting the high dose steroids, you will send, because you did right now the initial plan of management. After the high doses of steroids, you will refer here to the specialist. Just say specialist, or you can say even eye specialist. But the problem is that in some cases, they can be treated by neurologist and eye specialist, both of them. So just say, I'm going to refer you to specialist. Why do you want yourself, or why do you put yourself in trouble? Just say, I'm going to refer you to specialist because you're going to take a sample from the artery inside of your head. Okay? Okay. Is this reversible? Once it is established, okay. If once it is established, it's unlikely to be cured, but we can prevent the progress. Okay, we can prevent the progress. So if she is giving you total visual loss, you will tell her it cannot be reversed, but we can prevent the progress. Just say we can prevent the progress. But you do not tell her, I mean, just it's like a nice way to not say that yes, you are going to be blind. Just this is the way. And in the same way, by the way, or in the same time, you address the patient concern. You do not ignore them. Okay? Okay. So, once established, it is irreversible. But what we can do is that we can prevent the progression. Okay, guys? Okay. So, the next station is the angle closure glaucoma. Angle closure glaucoma, I like it personally. This station is quite easy, and when it comes, the score is high in it. So please study it good. Okay, in this station, you will find a lady. By the way, the presentation here is a red painful eye. Red painful eye. You are an A&E, the patient is female with red painful eye. When you enter the cubicle, you will find that the patient is wearing sunglasses. No problem, Dr. Lamia. Take your time. The patient is wearing sunglasses. She is sitting on a chair and wearing sunglasses, okay? Okay. Now you will ask her, how can I help you today? She will tell you, doctor, I'm having soreness or pain in my eye and it's red as well. Or she will tell you, doctor, I'm having a pain in my eye. I am so sorry to hear that. Which eye? She will tell you the right eye. Okay, can you tell me more about that, please? So she will tell you that this pain has started suddenly, like 2 hours ago, and it is in the back of the eye, and it is on the right side only, maybe. But still, you have to elaborate the eye pain in details. How to elaborate the eye pain? Since when it started, or when it started, how did it start? Has it been continuous or comes and goes? Has it changed? Anything makes it better? Anything makes it worse? Can you describe the pain for me? Does it go anywhere else? What about the other eye? And then you'll ask her about the score. Score the pain on a scale from 1 to 10. She can also give you headache. headache in one side. So here the presenting complaint, I wrote them to you. Number 1, red eye. Number 2, painful eye. Number 3, headache. Number 4, nausea and vomiting. Number 5, visual problem. Problem with her vision, like sometimes blurry vision. Sometimes she does not tell you that she is having red eye. So simply ask her, may I know why you're wearing these sunglasses? You know why she's wearing these sunglasses? Because she looked funny, but actually it's not good to say that she looked funny. Because the funnier the patient, the more chance that you will laugh or smile in an appropriate way, and the more the chance to be marked down. So in this station, actually, you will the patient may not tell you that she's having red eye. Red eye. So simply you can pick up that she's wearing sunglasses. Ask her, may I know why you're wearing sunglasses? She will tell you, doctor, because my eyes are red and sore. Ask her about this redness. When did it start? How did it start? Has it changed? Very simple. It is a simple complaint. Redness in the eye, like 3 or 4 questions. When did it start? How did it start? Has it changed? Okay. What are the associating symptoms here? The associating symptoms in the glaucoma are the halos around the light. Ask this question, please. Sometimes it can be present, some other times it cannot be present. So do not forget to ask this, because it is at least to show the examiner that you know very good about the glaucoma. Okay, this is characteristic for the glaucoma, so do not miss it. I'm sending it to you right now, the whole notes or the whole script. Okay, so the thing is that now we move to the DDs. What could be the DDs to the glaucoma case, guys? The differential diagnosis to the glaucoma are similar to what we spoke about just a few minutes back. What are the differential diagnoses for the glaucoma case? For glaucoma, still meningitis, GCA, SAH. I just sent it. Oh, you are not on the WhatsApp group, doctor. What's your name? I'm sorry. What's your name? Dr. Mahdi.
Hello?
Yes. Hello.
Yes, my name is Dr. Maria.
Maria. Okay, Dr. Maria. You are not on the WhatsApp group yet. I did not add you. I'll just add you right after the session, and I will post. You can take the notes from Dr. Mahdi. He's on the group. I will take a break maybe after this station for 5 minutes, and I will add you in the break. Okay. Because we are still left with at least 6 or 7 more stations for today. I will explain them in the remaining time. So we need to be a little bit quicker. No problem. Okay. So here in the past medical history, you need to ask about she will tell you in the medical conditions, she will tell you that she's having depression and she's taking amitriptyline for it. Unfortunately, one of the side effects of the amitriptyline is mydriasis. Mydriasis, which is pupillary dilatation. Pupillary dilatation, if the pupil is dilated, it will widen and block the hole in the side of the eye, through which the fluid is drained. So mydriasis will lead to blockage in the hole of the side of the eye, through which the aqueous humor or the fluid in the eye is drained. So this blockage will cause the fluid to accumulate in the eye, which will lead to glaucoma. So she's giving you amitriptyline. And ask also about the family history. I'm not saying that you should only ask these questions. No, you should ask about everything. But the most important things are the depression and the family history. Then in the lifestyle, you can pick up the smoking thing, very important as well. The only important thing actually is the smoking, if you want to ask in the lifestyle. Okay, then do examine the eye. Do examine the eye. Do not forget to examine the eye. Why? Because the examiner will show you a picture of red eye with dilated pupil. Okay? This, by the way, in this moment, if the examiner shows you any picture or if the examiner gives you any paper in the PLAB too. You have to excuse yourself from the exam, from the patient, and look at this. Okay. Okay. So after no funduscopy, Dr. Murad, we agreed that glaucoma is a contraindication to funduscopy. If you do funduscopy in the glaucoma, believe me, you will fail this station. Glaucoma, yes. You know what? Actually, I know someone. Subhanallah, this question came at the right time. I know someone who mentioned funduscopy in this station and he got 4, despite saying everything, but he got 4. Because if the patient is having very bad pain and you are still shining a bright light into their eyes, this is inhumane, seriously. Okay, so now you will ask in the management what you will say. Actually, by the way, no need to do investigations here. Do not say that I'm going to do ablation tonometry. You are FY2 guys. Wake up, you're FY2. How can you do ablation? I mean, there's even some ophthalmologists who cannot do ablation tonometry. So just say that, do not mention the examinations here because it's a local disease, local eye problem. Okay, so, and actually from the picture, you can diagnose glaucoma. So in the management, you're going to tell the patient, do you have any idea what could be the reason or what is going on? What's wrong, doctor? You will tell her that you're having a condition we call angle closure glaucoma. What is this, doctor? It is a condition in which there is accumulation of fluid in the eye due to improper drainage, which happens due to obstruction in the eye structure. You can find it in the notes. So accumulation of fluid due to improper or bad drainage due to obstruction in the eye structure. Why did it happen to me, doctor? Now you will tell her that, as I told you, it is due to problem in the eye structure. However, in your case, you could be having one of the reasons. Number one, there could be problem in the structure, like anatomical problem in the structure of your eye, which interferes with the drainage of the fluid. Or the other reason actually could be that the drug that you are using for the depression, one of the side effects is that it dilates or it widens the eye pupil and it will interfere with the drainage of the fluid. So number one, anatomical problem. Number two, the drug. What are you going to do for me, doctor? Number one, we're going to give you painkiller right now. We do not admit this patient, by the way, and you will know now what right now. You will give number one painkiller and anti-sickness medication because she's having bad pain and she's feeling nauseated. Number two, let's speak about the definitive management. Now you have to reduce the eye pressure. How? You will give some drops to lower the fluid production, which are the timolol drops. Then you can consider also giving IV acetazolamide. You will say, I'm going to discuss with my senior, and we may give you some medication as a drip in your blood vessel to lower the pressure in your eyes. Number three, you need something to do. Now you reduce the fluid, you need also something to do pupillary constriction. How? The pilocarpine drops. They constrict the pupil. Number four, you need also to reduce the inflammation in the eye. So you need to give steroid drops. Number five, treat the causative factor. I mean, after stopping all this, treat the causative factor, which is the medication. So you will review the medication with the GP. She may need either to switch to other drug or stop it. Number six, you will tell her or you advise her to remove the glasses. Why don't we remove the glasses from the beginning? Because you do not know yet that it's angle closure glaucoma in the beginning. But now I'm sure that it's angle closure glaucoma, at least from the photo. So you will advise her to remove the glasses. Why? Because staying in the dark can worsen her problem as well. Very good point that I remembered right now. Sometimes the patient may tell you that the eye pain started suddenly. She will tell you, doctor, yes, it started suddenly when I was watching TV. She's usually watching TV in a dark room. So now, this is one thing to pick up. Darkness actually aggravates the angle closure glaucoma. Why? Because in the darkness, your eye pupil will widen. If you are in the dark, you are more likely to open your pupil just to see better. Prolonged mydriasis will cause narrowing in the eye, in the peripheral eye hole. Okay, so narrowing in the eye hole, you know, the pupil when it dilates, it presses on the eye hole, so there will be no drainage of the fluid. So you'll advise her to remove the glasses because darkness may worsen her condition. Then comes the safety netting and warning signs. She will ask you, doctor, will it come back again? Okay, for that we are going to answer that we are going to give you eye drops to reduce the eye pressure on the long run. And number two, we are going to refer you to specialist as well. What will the specialist do to me, doctor? He will do some procedure to open or to widen the hole in the side of your eyes. It is called usually the total or peripheral iridectomy. It depends, but just say operation or procedure to relieve the narrowing in the side of your eyes to prevent the collection of the fluid back again. Doctor, will I go blind? At this moment, you will say that again, the accumulation of fluid will press on the blood vessel or in the nerve which supplies the eye. So the accumulation of the fluid will press on the nerve. So the chance of getting blind is higher. However, we started your treatment early, so the outlook is better here. So you will tell her that it can become permanent once established. But the good news is because why? Because the fluid will press over the nerve. But the good news is that she came early and we will start her treatment immediately. Okay? Okay. Remember that she does not have visual loss. She may have like partial visual blurring, but she is not having visual loss yet. So the visual loss is not established here. So you can reassure her by saying that we will start your treatment immediately. And the good thing is that you came earlier to us. Okay, this station is quite easy, a nice station. Your DDs here, you will find them in the corner. I'm sorry if they are not clear enough, but please mind that the DDs here are the most important DDs, as we mentioned before, beside the conjunctivitis as well. How to ask about conjunctivitis? You can simply ask any discharge from the eye. Dr. Islam, the GP can treat the depression. Depression can be treated in the GP. So you will refer her to the GP for the review of her medication. I mean, depression is one of the diseases which can be treated at the GP setting. Okay, and also an anxiety disorder. Actually, psychiatry in UK, we cannot stop the amitriptyline, Dr. Ella, because you do not know how her depression is progressed. So simply send her to the GP and he will review that. Just say we're going to send you to the GP to review your medication. That's very enough. Okay, this station was quite easy and it's quite nice station. So today I will practice this station, tomorrow I will practice this station in the beginning of the class with someone whom I will not tell. I mean, I will not tell the...
Dr. Ahmed, in
Yeah?
all OP settings where the patients are presenting with their pain, which painkiller, if sometime examiner asks which painkiller you want to give, should we say morphine here?
No.
Presentation, this is.
Listen, actually the examiner will not ask you which painkiller in the stations, except only in meningitis. Why in meningitis? Because this is the examiner. I told you that this is the meningitis examiner. She needs special treatment.
Okay.
In the meningitis, but usually the examiner will not ask you. But you can say only painkiller to stop. But you know, in the worst cases, if you are asking this question, if the patient tells you from the history that they took paracetamol and it didn't help, this means that you need to give stronger painkillers. What stronger painkillers? You can give like ibuprofen, anti-inflammatory stronger painkillers, and you can also give her codeine if you wish. But just please, before moving from the pain ladder, like before prescribing codeine, you better mention that I'm going to review with my senior.
It's better.
Okay.
Okay, thank you.
You're welcome, Dr. Yasmin. So give me 2 minutes break, guys. This is 2 minutes only, and this is a short break because we are really late today. We started late and we talked late. Starting from tomorrow, the session will be faster a little bit. Okay, 2 minutes and I'll be back. Hello, everyone. Sorry for the break. Dr. Masih was asking a question. You know, Dr. Masih, in the beginning of the station, when you practice with me, inshallah, you will try introducing yourself to me. You will tell me, can I confirm your name, please? I will tell you, Doctor, my name is Robert. What would you like me to call you? He will tell you, call me Robert. So the patient tells you that, call me something. So definitely call him Robert. Just call him Robert. Very enough. Those people are easy. They are open-minded. Yes, that's a good point. That's why you do not need to address him throughout the station. Just say you, you, you. You told me. Don't say, for example, Robert, you told me, because you are having 18 different patients. So it's better not to mention name. Only in one station or few stations that you better remember the name, which is dealing with your colleague, which is teaching stations. Okay, those stations are very good to remember the name because this is essential in the report, or this is good in the report. However, you know what happened to me in the knee teaching station? In the knee teaching station, you are having two people. The simulator. Yeah. Dr. Kashi, actually, you are going to ask the patient, can you confirm your name and age for me, please? However, if you forgot about the age, it's not a big deal. Just the name is a good thing. Just this is the patient identity. What happened to me in the knee teaching station, I got confused. For example, the student was called David and the simulator was called something else, I think Louis or something. So I got confused in the middle of the station. I told the simulator David, and he told me, no, doctor, I'm Louis, and the doctor is David. So you know, you will get confused if you keep calling the name too much. So just try to avoid this as much as possible because this will embarrass you or put you in trouble. Okay. You can confirm the age, Dr. Kashi, as we said, but if you forgot about it, no problem at all. I mean, even most of the academics do not confirm the age of the patient. Okay. Now let's do the cough stations. Cough stations are very easy stations. Very easy, but there is a problem. They are a little bit confusing. Why confusing? I will tell you why confusing. Because they are quite similar to each other. So being similar is a merit, and at the same time, it is a disadvantage. Okay? So what I need you to do, only to pick the important differences between each cough station. Let's start with one of them, which is the mesothelioma. It is most probably mesothelioma, but I do not say it's mesothelioma. I'm just saying that it is most probably mesothelioma. Most probably mesothelioma. Please do not mention mesothelioma to the patient. Just say that it is most probably mesothelioma. Okay? Okay. This station is challenging. Why? Because it can change. It can change sometimes. Some examiners may change it for you. They can give you some different findings. So they can give you some other things as well. Okay? So what I'm going to do right now, I'm going to show you how it works. Okay. In the mesothelioma station, you will enter the station. You will find, or you will, sorry, the task will tell you your FY2 in A and E. Your FY2 in A and E, and the patient, or you can even be in medicine department. The patient is having cough. Cough. Talk to the patient and address his concern. The patient, by the way, is usually old age patient. Not very old, but I mean like just above 50 years old, at least. So the patient is 50 years old and beyond that. Please remember the age. Memorize the age very well. Okay? Okay. What I'm going to do right now, I'm going to elaborate the cough. Very important to elaborate the cough. Doctor, I'm having cough. For that, actually, I'm going to ask the patient, tell me more about this cough, please. What you want to know, doctor? Here, what you want to know from the patient, you would want, first of all, you will tell the patient, when did it start? How did it start? Has it changed? Has it been continuous or comes and goes? I told you yesterday that there are some few important questions to ask in the cough, right? Right. Which important questions? Is it dry? Sorry, is there any phlegm? Is there any blood? Why? Because these two questions are quite important to ask in the cough. The dry cough is totally different from the productive cough or the phlegm. So the patient will give you dry cough, which has been there since 6 months, and it worsens on gardening. Always remember this. The cough worsens on gardening. Worsens on gardening. Again, I'm stressing on this because you will be asked about this in a while by the examiner. Okay? Okay. So what I'm going to do right now, I'm going to, yeah?
Sorry, I didn't get what you said just now. The cough worsens what?
Gardening. Means that he's got,
Gardening?
yeah. Means that, you know, when he was like watering the plants or like arranging the garden or so.
Thank you.
You're welcome. So, cough which worsens or gardening, right? The patient also has some other complaint. Which other complaint? The patient is showing you most probably that he is having shortness of breath. Shortness of breath here is challenging a little bit because he will tell you that the shortness of breath is worsened on lying flat. It is worsened on lying flat. Okay? So this shortness of breath is worsened on lying flat, which means that there is a possibility of heart failure. So for the gardening, there is a possibility of asthma. For the shortness of breath which lying flat, there is a possibility of heart failure, because the examiner will ask you about the differentials after 6 minutes. So the presenting complaint is cough and shortness of breath. Elaborate them. You will find only the relevant thing which I told you about. I'm going to send you a photo for it right now on the WhatsApp group, just to make sure that you know about that. Associating symptoms to any cough. What are the associating symptoms? Chest pain. This is number 1. Number 2, weight loss. Why weight loss? And loss of appetite. And anemia symptoms. You know why? Because this is long-standing cough. Long-standing cough, which is dry, and long-standing shortness of breath as well. This points you most probably toward cancer. So you have to ask about cancer symptoms here. So please make sure that you mention them. Okay? I sent it to you right now. I'm sending it to you actually. Here the cough simply and the chest pain tray comes. It can be positive and it cannot be sometimes. It depends. The weight loss sometimes is positive. The loss of appetite. Please look at the note that I sent you. The loss of appetite sometimes can be positive as well. There can be anemia as well. Anemia symptoms. How to ask about the anemia symptoms? Doctor Islam. How to ask about the anemia symptoms? Dr. Islam, how we ask about the anemia symptoms?
Hello?
Yeah?
Anemia symptoms, we can ask about, do you feel tired?
Exactly, what else?
Any dizziness?
Okay, good. Sure. He gave you shortness of breath already, right?
Yeah.
Okay, perfect. Thank you, Dr. Islam. So only 2 questions for the anemia symptoms are quite. I remember, you ask about cancer symptoms here for one reason, and that the patient is giving you long-standing cough and shortness of breath, which can point most probably toward cancer. So please do not overlook this. Okay? Okay. Now, I'm going to ask about the fever as well. In any cough station, you ask about chest pain and fever and shortness of breath. But here, since there is a possibility of cancer, you can ask about weight loss and loss of appetite because it is long-standing cough. Okay? Okay. What else? After that, you have to do the differential diagnosis. What are the differentials here? Number 1, cancer. We asked about cancer symptoms. Number 2, TB. How to ask about the TB? You simply ask if there is shivering or night sweats. Please, you write it yourself, shivering or night sweats. Pneumonia, you asked about it already by fever. Asthma, you do not need to ask about it. Heart failure, you do not also need to ask about it. Why? Because he gave you shortness of breath, which worsens on lying flat, which you can point towards heart failure, and he also gave you cough, which increase on gardening, which can point toward asthma. Okay. So, what is the past medical history you need to ask here? You know, guys, in the past medical history, a very important thing to ask here is the family history. Family history, why? Because the lung cancer run in family. Number two, because the close contact to someone who's having similar symptoms. Guys, any infection in the body or any infection in the PLAB2, you have to ask about close contact, either respiratory infection or skin infection or whatever. You better ask about close contact. So simply ask any close contact to someone who has got some problems. Okay, okay. Then, in the past medical history also, you can ask about if the patient is diagnosed with any smoker cough or not. Lifestyle, no need to stress on the smoking, and diet and physical activity. You can ask all the lifestyle here actually. No problem at all. Now ask also about the job. Please write beside the job alarm. I need you to write an alarm. Why? Because in the job you just do not need to ask about the recent job. You also need to ask about recent job and previous job and if he was ever exposed to asbestos or not. Maybe he's working something else, but just till 2 days before he was working as a carpenter and he was exposed to asbestos for 20 years. So please ask about the previous job. Ask also about travel. Why the travel? Because the travel can point toward the TB and can point toward chest infection as well. Okay? Good. Now do the examinations. Which examination we need to focus here? As any examination, but add respiratory examination. And on the examination, you will find reduced breath on one side of the body. One side of the body. Okay? Okay. Please mark this. Reduced breath on one side, which means that there's a problem on one side of the body or one side of the lungs. Okay? Okay. Now move to the investigations. Usually the examiner will keep quiet because he needs you to disclose the examinations to the patient after disclosing the problem. The examiner will stop you and ask you, doctor, what are your differentials here? You will tell him, number one, lung cancer, mesothelioma. Why? Because the patient is having dry cough, since, for example, that long, and shortness of breath. Number two, the patient is smoking, or a smoker, heavy smoker. Number three, as well, the patient was exposed to asbestos. So you will pick from your history what's relevant. Okay, okay. What else? Let's speak about other differential. The other differential is TB. Why TB? Because the patient is having cough and shortness of breath, number one. Number two, the patient is a smoker and he was exposed to his son. Or he came in contact with his son who lives in endemic area. If he ever gives you this as a history. Number three, it could be also asthma because the patient is having cough and shortness of breath from the history. And also the patient and this shortness of breath is worsened on gardening. It could be also heart failure. Why heart failure? Because the patient is having shortness of breath which worsens on lying flat. So please, you can complete them. Asthma is due to cough which worsens on gardening and shortness of breath as well. Heart failure is due to shortness of breath which worsens on lying flat. Mesothelioma, he is coughing and shortness of breath and smoker and exposed to asbestos. TB, cough and shortness of breath and close contact to someone with similar symptoms. Okay, I hope this was clear. What is the management here? You know, I wrote it only in few notes. You know why I wrote it in few notes, guys? I really meant to write it in few notes because this is a challenging station. You will tell the patient, it seems to me that you're having problem in your lung. Which problem, doctor? At this moment, we need to do further investigations to find out the cause. Which investigation? I wrote to you 4 arrows, right beside them. Number 1, we need to do routine bloods to see if you have any infection in your blood or not. Number 2, we need to do chest X-ray and CT scan to find if there is any problem in the structure of your lung. Number 3, we need also to take sample. We need if there is any build of fluid around your lung, which is pleural effusion, you're going to take a sample from it. Number 4, we need to take a sample from your sputum or from your phlegm. But doctor, I do not have phlegm. This is very good. We need to do some procedure to induce the production of the phlegm, which is called physiotherapy. So just say we need to do some procedure to induce the production of the phlegm. Okay, okay. What else? Now we are going to do we are going also to do one procedure, which is a camera test to look inside your lung. So number 1, blood. Number 2, chest X-ray and CT scan. Number 3, sputum analysis. Number 4, pleural effusion aspiration. And number 5 is bronchoscopy. We can do it as well. Okay, what is doctor? Then doctor, could it be cancer? May I know why you think so? Because doctor, you told me many investigations, and actually I'm really worried because my friend has got lung cancer because he was having long-standing cough as well. So you will tell him, I'm really sorry for your friend. Please do not worry about that. We're all here to help and support you. At this moment, it's difficult to say. We need to run further investigations, as I told you. However, cancer could be a possibility. Why cancer, doctor? Now you will tell him that why cancer? You will tell him that it could be a cancer we call mesothelioma. Okay, I have a very good idea. When someone asks you about the mesothelioma, you will tell him it's a type of cancer which occur due to the asbestos, which is tiny materials when they are stuck in the lung over a long time because irritation in the lung. And that's why it leads to cancer development. Okay, so mesothelioma is one possibility. What is the next possibility? The next possibility is the TB. Why TB? Simply, it is a lung infection, most probably droplet infection transmitted from one person to another. And it happens when you come in contact with someone with similar symptoms. You told me that you have come in contact with your son who is living in, for example, he was living in some endemic area. Okay, so this could be one of the possibilities. However, we need to run further investigations to find out the real reason. Okay, doctor, thank you. This is a station. Why it's challenging? Because the examiner will ask you about DDs. Why it's easy? Because you do not need to say diagnosis. But please, when you are coming to the cancer, actually this patient is having symptoms suggestive of cancer. So at least you need to say that it could be a possibility. He will ask you which type of cancer, say mesothelioma. It is a type of cancer which happens in the layer or the outer layer of the lung. Okay, why it happens? Due to the tiny materials which are the asbestos. When they get stuck inside the lining of the lung, they cause irritation, prolonged irritation, which leads to cancer. Okay, what else? It could be also TB, tuberculosis. Okay, one important thing. This is station, you can score 12 in it. This is easy station. What could fail you this station? What could fail you this station is that when the patient asks you, could it be cancer? You will say to him, yes, it is a cancer called mesothelioma. You know it's cancer. I told you many times that you cannot diagnose cancer except after invasive procedures. If you miss this part, you are likely to fail. So please write down that we cannot disclose the cancer under any condition except after doing the invasive procedures, which are the sample. Okay? Okay. I hope we were clear so far in this station. It is very easy station, by the way. The DDs here again. that you will say to the examiner: cancer, TB, asthma, and heart failure. And explain each of them. Why you think cancer, why you think TB, why you think asthma, and why you think heart failure. Now, let's move to similar station, but it's a little bit challenging. Why challenging? Because the people confuse it with the mesothelioma. It is a PCP. You know what? In the PCP, simply, I need to give you some few tips in the PCP station. What to do in the PCP station? The PCP station, first, you have to know the PCP stands for Pneumocystis carinii pneumonia, PCP. And I'm going to send you the script or the note for it right now. Okay, the patient is young age. This is number one. You think that mesothelioma or lung cancer can come to someone who's 27 years old? No. This is number one. Number two, the patient is homeless. The patient is sexually, I can say that he's sexually more active than usual. He is homosexual, and sometimes he has some few night stands. One more thing as well is that this patient is having recreational drugs. So the GMC is giving you a case of the patient who is having many findings to be immunocompromised. Like he could be likely having HIV actually. So the PCP usually comes to the people who are very weakened. So that's why you have to pick this up. Some people may disagree with me and they can tell me that, oh, okay, also the TB can come to the people who are immunocompromised. Yes, that's true. But believe me, there will be close contact to someone who got TB. I mean, the person will give you a history of close contact or even travel to an endemic area. But in the PCP, no. The patient is only immunocompromised and homeless and homosexual and recreational drugs. I sent you the notes for it right now. Please read the notes very well. You will find that I wrote cross mark beside the home and the job. Because this means that the patient is jobless and he's homeless. And he is drug abuser and sexually active, like more than usual. Okay? Okay. What else? Now let's start. The presenting complaint is shortness of breath and dry cough. Usually the patient will start the station by telling you, doctor, I cannot breathe. Are you comfortable to talk? No, doctor, I cannot breathe. So now you're going to pick the news chart. There is a news chart in this station. You will pick the news chart and you'll find that the oxygen is low. So simply you're going to attach or you're going to give oxygen to the patient. Not attach, you just verbalize that I'm going to give oxygen. The examiner will tell you, assume doctor. And now tells the patient, are you feeling better? Yes, doctor. So tell me more about that. He will tell you that this shortness of breath started maybe a few weeks back and it's getting worse on its own. Sometimes it gets worse in activity. I mean, nothing conclusive. It is just shortness of breath which gets worse on physical activity. What else? He will tell you that he's having cough. Tell me about this cough. Again, it started a few weeks ago and it gets worse on physical activity, but it is dry cough. So now you have shortness of breath a few months ago and cough which started a few months ago as well, and the cough is dry. So always remember that the cough is dry. The cough is dry, okay? Again, the cough is dry. What is the associating symptoms to the shortness of breath and cough? Again, chest pain, fever, loss of weight, loss of appetite, night sweats, and fatigue. Why I'm asking all these questions? Because it is long-standing cough and shortness of breath. So I need to rule out cancer and TB as well. I know that the age does not point toward cancer, but at least TB is a possibility. So those symptoms point as well towards TB. Loss of weight, loss of appetite, night sweats and fatigue and fever, and chest pain point toward TB. You can find chest pain which increase on activity as well. You can find low-grade fever, and you can find loss of weight. You can find actually everything in this station. All the symptoms that you ask, you will find them positive. This guy is really weakened. What are the differentials here? Differentials here are again TB, cancer, and asthma. I wrote also pulmonary embolism. Don't mind about it. Just ask about TB and cancer and asthma, which you already ruled out from asking many questions. In the past medical history, you have to ask him about any recent infection. Any infectious or any lung problem, you have to ask about any recent infection. Why? Because any cough or shortness of breath can be precipitated by recent infection. And also, this patient is immunocompromised. So at least when you ask him about any medical conditions, ask him about diabetes or any immunity problem. Then I told you it's an infectious problem, so ask about family and the close contact to someone who's having similar symptoms. Q2, this is good. Q2 here means is recent health. I told you in the past medical history, number 1, you say, have you had any previous episodes? Number 2, how was your health recently? Number 3, do you have any medical condition? Number 4, do you take any medications? Number 5, do you have any allergy? Number 6, recent hospitalization. Number 7, surgery. Number 8, family history and the close contact. Okay, lifestyle. You'll find the patient is smoking and he's drinking alcohol and he is not physically active and he is having poor diet. Social history, you will find that the patient is homeless and he is jobless and he is drug abuser. And please, before asking about the drug, say, by any chance, do you use any recreational drugs? Ask him about sexual activity as well. Why? You know why. Because this patient is homeless and jobless, so at least he could be more sexually active. And you'll find that this patient is having multiple relations and he's sometimes homosexual. And I mean, actually, he's bisexual, actually, what comes in the GMC exam. But ask about it, okay? Ask in details. And to know how to ask about sexual health, please move back to the history. Move back to the history which we taught yesterday. I will just add 2 questions and I will send them to you. Okay, now do the examination portion, which is vitals, general physical, and respiratory examination. You will find the low oxygen saturation and the reduced air entry bilaterally, and please mark the word bilaterally. Mark it and please stress on it. Because in the PCP, the air entry is reduced bilaterally, but in the tuberculosis, it is reduced unilaterally. PCP is in the form of multiple patches all over the both lungs, but TB is cavitation in one side, mostly. We need to do some investigations. Which investigations here? We need to do ABG, bloods including ABG and chest X-ray. So routine bloods including ABG and chest X-ray. Why ABG? Because this patient is having shortness of breath and prolonged shortness of breath. So you need to know if this patient is having or is going into respiratory failure or not. So please ask about the ABG, the blood gases. This is prolonged shortness of breath. In any prolonged shortness of breath, ask about the ABG. We need also to do chest X-ray. Why chest X-ray? Because actually this is bilateral. You will find bilateral patches all over the lung. And I wrote you bilateral in black font. What is the management of this case? You will tell him that you're having a condition we suspect a type of lung infection we call PCP. What is this, doctor? Simply, you will call him or you will tell him that this is sort of lung infection caused by a bug, which causes like scattered patches all over the both lungs. And it usually occurs due to weakened immunity. So it happens, or it causes scattered patches of infection all over the lung caused by a bug called Pneumocystis carinii. It happens in weakened immunity cases. Number 4, it can cause also buildup of fluid around the lung. Doctor, why did it happen to me? You told him that it happened to him because he's weakened. What are you going to do for me? Again, we're going to do investigations like the previous station, bloods and CT scan and chest X-ray, and sample from the fluid around the lung, and sputum analysis, and please add also bronchoscopy. We can do it. But please, I need you to stress on one thing. We need to offer him HIV tests. You will tell him in this very nice way. This disease can occur in the immunocompromised or the weakened immunity case. So would it be okay with you if we order HIV test for you? Yes, doctor, please. So offer HIV because you know that he could be HIV. By the way, there is a strong association between the PCP and the HIV. What will be the treatment? This patient was admitted because of shortage of breath, and as well he's homeless and he's jobless and he doesn't have any resort. So number one, you admit him, definitely. Number two, you can ask your senior if you wish. It's not a big deal here. I mean, you can or you cannot ask, no problem. But more importantly, you will give him oxygen because of his shortness of breath, and you will give him two things definitively. What is a definitive management? Number one, antibiotic, because it is lung infection. Which antibiotic? Contraindication IV. Number two, we're going to give him steroids. Why? To reduce the inflammation or to prevent the inflammation in the lungs. So antibiotics and steroids, those are the core of the infection or the core of the station. EC station, yes, very easy. But long history, very long history, because you still have to elaborate sexual history, and you also have to elaborate the job, and you elaborate the drug abuse, and you have to elaborate the home conditions. Where does he live? You will elaborate the lifestyle in details. You will elaborate as well many symptoms, including shortness of breath and cough and chest pain and fever and loss of weight and night sweats and loss of appetite and fatigue. Actually, this patient is having very much findings. That's why it's easy patient, so you cannot miss it. Okay, okay. From now on, if there is no notes written, I will write the notes after a while, inshallah, after we are done, and they will be sent to you tonight, so that Dr. Masih will read them in the early morning. Dr. Masih, if you do not read them in the early morning, okay, you will pay a fine. Now you will find it's back again.
I'm gonna read.
Yeah, you will read. You know what? In the early morning, you will wake up and you will wash your face, drink a cup of tea, and read the notes before doing anything. Okay?
Sure.
Your exam is the day after tomorrow, and you have to be ready from today.
Sure.
I'm kidding, man, okay?
No way.
Thank you. Dr. Islam asks, can I review the cause of infection with HIV? No, Dr. Islam. He's just immunocompromised. So you do not know yet. Just say that your immunity is weakened. Just say so, because you do not know yet. Yes, I'm sure he will be having HIV, but you know, HIV is breaking bad news. So you cannot do it unless you have a very good clue or you have like a confirmation that it's HIV. Okay? Okay. Let's move to the EC station, the TB station. Dr. Bina, you know, this is one reason that we need to admit him right now. His homelessness. His homelessness actually is one of the reasons we need to admit him. We need to admit him right now because it is unsafe to let him go. So just say that we need to keep you in the hostel for two reasons: the shortness of breath and the bad cough, and number two, his homelessness. If you ever have time, by the way, if you ever have time, you will tell him that we'll contact your GP if you are registered with GP to arrange a home. But you know the problem is that this patient is not registered to GP and he doesn't have any family, he doesn't have anything. So you will end up contacting social services for him. But as I said, do not jump to the further plan of management unless till you address the current issue, which is the shortness of breath, the bad shortness of breath. Okay, okay. Next station is the bronchogenic carcinoma. No, the TB, sorry, the TB station. We are left with 4 stations or 5 stations, and we will finish them in 45 minutes. Don't ask me how, I will do it. I'm not going to rush it, and I will finish them. Okay? Okay. So we will finish 15 minutes late today because we started late. But starting from tomorrow, we'll be quite fast, and even while teaching, I'll be a little bit faster because now you know the scheme and you know everything, how to ask. Okay? After the session, inshallah, every day, someone will come and practice with me in person. If you want to attend it, it's fine. If you do not want to attend it, it's up to you. Okay? Okay. Let's speak about the TB station. The TB, actually, it is one of the best stations that can come to you. Why? Quite clear. You do not even need to study it. The task will tell you that you're FY2 working in E department and the patient will be like middle age, could be like 40 years old patient or something, and he's having cough and shortness of breath. So the patient is having cough and shortness of breath. You know, guys, this station is very similar to the PCP. You do not even need to study it. The only difference is that he's having phlegm and the blood in the cough. So this is the only difference, phlegm and the blood in the cough. So productive cough or productive cough with blood, with streaks of blood, okay? Productive cough with streaks of blood together with shortness of breath, okay? This means that he is most probably having TB. Why TB? Because after a while you will get to know that this patient is having travel history or contact to someone. So productive cough with blood and shortness of breath and recent travel history or contact with endemic area, this points you toward TB. No need to think. And in the examination, you will find reduced air unilaterally. Definitely TB. Why not lung cancer? Very good question to ask. Okay, the point is that actually here you have all the clues toward chest infection or TB. Low grade fever, you will have it. Shivering, you will have it. Loss of weight, you will have it. Fatigue, you will have it. Everything you'll have. What points you toward the TB and not the lung cancer? Because he's having recent travel history. He's only having recent travel history to endemic area. Okay? And his job does not point toward any asbestos exposure. And guess what? In the examinations, you will find reduced air entry on one side. And guess what as well? This problem started 2 months ago. 2 months ago. So, you know what? In the bronchogenic carcinoma or the lung cancer, it is most probably hemoptysis. Hemoptysis and only hemoptysis, together with asbestos exposure or like some job in asbestos, okay? And you'll be having the chest X-ray may not, the examination will also show unilateral decrease in it. But very important thing, the chest X-ray here will show you reduced marking in the right side, reduced lung markings in the higher side. Sorry, increased marking in the right side. Increased markings points you toward infection. Bronchogenic markings are most probably pointing you toward lung infection. So it is most probably due to TB. So again, not to confuse yourself. Cough with shortness of breath and the cough is productive and associated with blood. What could be the associating symptoms to the cough and shortness of breath? Again, number 1, fever. Yes, it will be positive. Number 2, loss of weight. It will be positive. Number 3, loss of appetite. It will be positive. Number 4, shivering. It will be positive. Number 5, you can find also as well fatigue or night sweats. It can be positive. He is very similar to the PCP, but his age is older and he's having current or recent contact to someone who is infected or showing similar symptoms. So the clue here is recent contacts. And in the chest X-ray, there is increased bronchovascular markings. Okay. Okay. This patient has traveled to South Africa recently, just a few weeks before the cough starts. Okay. Just one hint. What if I pick Dr. Who? Let's pick someone. Dr. Mahdi. Dr. Mahdi? Okay, Dr. Yemi, are you here? Yemi? Guys, are you sleeping or something?
Dr. Masih is here.
Huh?
Dr. Masih is here.
Excuse me, I can't hear you. Oh yes, Dr. Mahdi. Yes. So Dr. Mahdi, can you hear me?
Dr. Ahmed, I can hear you.
Okay. Dr. Yemi as well. Guys, you think my voice is reaching you late or something? Because I noticed that the people reply like 1 minute later. Okay, Dr. Mahdi, I need you to ask me how to elaborate the weight loss. Quickly, Dr. Mahdi, please. Okay, I will write it by myself here on the chat here.
I can ask.
Okay, ask quickly.
Okay. Have you lost any weight recently?
No, doctor.
Okay. Has anyone in your family or in your friends have noticed that you are losing weight?
Yes, they told me that I've been losing weight, doctor.
Okay. And could you please tell me how much is it?
I think, doctor, around 5 kilograms or something. He told me so.
Okay.
You know what?
And within a span.
Yeah, this is good. This is what I needed from you. Number one, you will ask the patient, have you lost any weight? Number two, he will say no. Have you been told by anyone that you have been losing weight? He will say yes, doctor. My wife tells me so.
Okay. And is it intentional or not?
Okay, very good. No, doctor, it was not intentional. Thank you, Dr. Mahdi. So for the weight loss, I will write to you. You need to ask number one, have you been losing weight? I will write it to you here on the group. Have you been losing weight? Number one. Number two, how much? And over how long? Number three as well, was it intentional or not? What if the answer to the question number one was no? Number one, no? Then ask him, have you been told by anyone that you have been losing weight? I hope this was clear enough. So, here in the history, I told you everything. Like any CUP station, the CUP station, do not forget to ask about the job, do not forget to ask about the travel history, and do not forget to ask about sexual history. Why do I take sexual history in the CUP stations? Because sexual history can give him AIDS, which makes him immunocompromised and more likely to get TB or PCP. Here in the examinations right now, we will verbalize the respiratory examination. You will find reduced air entry on reduced air entry on the right side. And you can find low-grade fever. And this is also one thing to exclude cancer. Low-grade fever points you more toward TB. So you have here 2 clues or 3 clues toward TB. Number one, low-grade fever. Number two, contact history. Number three as well is the increased bronchovascular markings in the chest X-ray that you are going to mention. Okay, okay. What is the management here? You will tell the patient, do you have any idea what's going on? You are having a condition from my assessment, it's called pulmonary tuberculosis. What is pulmonary tuberculosis? Droplet infection due to some bacteria which spreads through inhaling droplets, through cough or sneeze from an infected person. So it is droplet infection, happens due to cough or sneeze through an infected person. What are you going to do for me, doctor? You know what we are going to do for this patient? Number one, keep him in the hospital. Why? You know why? Because this person has been having this symptom since at least 2 months. 2 months mean that he has become quite infectious. And he's having cough and shortness of breath at the moment. So you need to keep him in the hospital right now. You cannot send him home. He is symptomatic. He is not asymptomatic, he is symptomatic right now. And that's why he came and he is having probably a cough and shortness of breath. Okay? And you can find, by the way, that his respiratory rate is high. So this means that he needs admission. Okay? Okay. So what are you going to do for me? Now you will speak about, number one, we will shift you to a separate room. Why? Because he's coughing. He's infectious. You need to shift him to separate room, number 2. Number 3, ask senior, number 2, ask senior to come and review. Number 3, shift him to a separate room. Number 4, what are you going to do? We are going to do some investigations. Which investigations? Please, they are, I will tell you right now, Dr. Maria, again. So which investigations, guys? The investigations like the previous station typically. For any cough or any shortness of breath station, you will do all these examinations. Please, you will mention them in all the stations, guys. Okay? Okay. Then, what are you going to do for me, doctor? You are going to give him a combination of antibiotics after confirming the diagnosis. Okay? Okay. What combination of antibiotics that you are going to give to him right now? You will give him number 1, isoniazid. Number 2, rifampicin. Number 4, ethambutol. Okay. Number 4, pyrazinamide. So isoniazid, rifampicin, ethambutol, and pyrazinamide. You do not even need to mention names in PLAB 2. You just need to say combination of antibiotics to clear the bug. The first question he will ask you, doctor, do they have any side effects? I will send them to you in the notes right now, but you will simply say that one of them can cause liver problem. So we may need to check your liver function before and during the treatment. The other one can cause problem in the eyesight or the vision. So we may need to check your eyesight before starting it. The other one as well can interfere with the vitamin level in your blood. So we may need to give vitamin supplements to you. Number 4, some of the medication or one of them can interact with all the other drugs. So it's better to be informing the treating doctor or the doctor treating you that you are taking this drug. I will send them to you in the notes. General advice and warning sign. Doctor, should I look for anything? Yes. You will advise him that he should take these treatments regularly. He must take them regularly because if he is not compliant with them, he may likely to develop the symptoms back again. The course of the treatment. The course of the treatments, you will start with 4 antibiotics for 2 months. And you will continue only with 2 antibiotics for the next 4 months. So the 4 antibiotics will be taken for 2 months, but isoniazid and rifampicin will be taken for 4 months, for next 4 months. So the whole course is 6 months. What are the warning signs? You will warn him about like the tingling, and you warn him about the jaundice. You will warn him about as well the eye problem. You will warn him about the cough. The warning signs of the medication side effects and the warning signs of the the disease itself. How to prevent that? Please make sure that you give him some advices, like avoid public exposure. If he is staying in a room, try to maintain good ventilation in it. Try to at least avoid the people or be isolated for the next 2 to 3 weeks. Why? He needs to be isolated at least for 2 to 3 weeks from now because there is a risk of transmission of the infection throughout this period. He's quite infectious through this, or especially till the treatment is established. He needs to abstain from people or isolate himself from the people. Okay, so isolate yourself at least for the next 2 weeks and maintain good ventilation in any place. I mean, do not stay in closed places. It's very important. And please stay away from the children and immunocompromised people and the school because he's working as a teacher. This is a station. And it's a very easy station, by the way. I used to like it very much because you all know about it from your medical school, from anything. Number 2, Dr. Maria. Number 1, we are going to admit the patient. Number 2, we are going to do senior review and we will shift the patient to a separate room. Why we will shift him to a separate room? You know, because someone who's having TB is quite infectious, right? So if he's quite infectious, there's a risk of transmitting this to other people. So we need to shift him to another room. TB is highly infectious disease. TB is highly infectious disease, guys. Please do not underestimate this. because some people do not think that we should admit him or we should not separate him. Okay, next station is one cough station. Next station is hemopsis. If the station tells you, or if the patient tells you, by the way, you're FY2 in A&E as well, sometimes in respiratory department, the patient is coming with blood cough. So hemopsis is presenting complaint. Okay, the patient will tell you that I'm coughing blood again. And sometimes he's having shortness of breath. You will elaborate it like the previous stations exactly. Cough, shortness of breath, fever, loss of weight, loss of appetite, night sweats, what else? Shivering. You also ask about maybe any chest pain. But important thing, or the only difference, is that the cough here, it is productive cough and there is blood. So I told you yesterday, if there is any discharge, which is like the phlegm, you will ask when did it start, you will ask about the amount, you will ask about the color. And what have you done for that? He will tell you, I went to the GP and he gave me some antibiotics. What about the blood? Again, for the blood, you will ask him about the color, the amount, and when did it start. There is only one problem in this station, that he is having episodic hemopsis. When someone is telling you episodic complaint, you will ask him about number one, number of episodes. How many episodes did you get? Number two, when was each episode? And I will write this, I will add this to our notes as well. So timing, number two. You will ask him about each episode in separate. Like for example, if he given you only 2 or 3 episodes, elaborate each episode. Why? To be able to know the difference and the progression of the disease. Because if the episodes are getting worse, this means that the disease is progressing. Okay, like for example, you ask the blood about the amount and the color. Okay, now let's move to the past medical history, which is very important. In the past medical history, you can ask about, again, in the question 2 or the recent health, you can ask about any recent infection. In the medical diseases, you can ask about any smoker cough. By the way, this guy is having COPD. As I told you, in any cough station, you need to ask about recent infection and about COPD. Personal or lifestyle is very important. You'll find the smoking is very conclusive here. The job as well, sometimes he can be exposed to asbestos, some other times not. Now let's move to the examinations. In the respiratory examination, sometimes the examiner may give you clubbing in the hand. He may give you fullness on the supraclavicular area. You know this? This is definitely bronchogenic carcinoma. Sometimes the examiner will not give you this. He will just only give you decreased breath sound on the right side. I need to do some investigations as well. Which investigations? Blood and X-ray. Again, for any cough, the initial investigations are blood and X-ray. What will the X-ray show? The X-ray here, in the examination findings, Dr. Murad, in the examination findings, the examiner will give you that there could be clubbing in the hand. He can also give you fullness in the supraclavicular area. This means that it is probably bronchogenic carcinoma, you know, metastasis or lymph node swelling, the fullness in supraclavicular area. And on auscultation, he will give you decreased breath sound on the right side, which is the side from which he is complaining of chest pain. Or he is the side which he feels shortness of breath. Okay. Now with the chest X-ray finding, there will be, sometimes there will be pleural effusion. He will give you X-ray, you will read it. You can find pleural effusion fluid or some fluid like opacity surrounding the lung, a line of opacity, and you can find round opacity on the upper border of the lung. So there is pleural effusion and there is opacity in the lung itself. Okay? So opacity and pleural effusion, definitely, this is pleural effusion is due to the lung cancer. So here, please, guys. Now, management. The management, you will tell the patient that you are having a problem with your lung. Doctor, what are you going to do for me? You know what? Here in this case, you have to explain to him that we did chest X-ray to you, and you have to explain the result of the chest X-ray. You will tell him, you will show him that there is buildup of fluid and there is an opacity in the lung. Show this by yourself to him. So we are going to do further investigations beyond that. What will you do to me, doctor? You will say the same investigations for any cough, as we mentioned, CT scan, sputum analysis, and pleural fluid aspiration, and bronchoscopy as well. And what else? And you can also do thoracoscopy, if you wish. Okay? Doctor, is it serious? May I know why you think so? Because, doctor, you told me many investigations. I told at this moment, actually, we need to do further investigations to know. Doctor, is it cancer? May I know why you think so again? Because, doctor, my friend has got lung cancer. Well, at this moment, it's difficult to say. We need to do further investigations. However, I'm afraid cancer could be a possibility. This is the station. Very similar to the past ones, but the only difference is that he's having episodes of hemoptysis. So, and you also need to read the X-ray by yourself and explain it to the patient. Okay. Next station is, we are done with this station. Let's move to some EC stations, which are the sepsis station. Let's agree on something. I will just provide you with some notes in sepsis stations. I do not need you to remember scripts for sepsis station. Why? Because sepsis stations are having at least 10 scenarios right now. They change it like 40 times per day because it can be changed easily for each and every candidate. I need you only to remember one thing in the sepsis stations. The patient will be presented with cough and shortness of breath. Again, this is chest infection. This is like pneumonia. But the difference between the pneumonia and sepsis is that pneumonia is just lung infection, cough and shortness of breath and some fever. But in the sepsis, it got worse. It means the pneumonia has got worse. And there are some other findings as well. Like what? Let's speak about the other findings that could the patient get after the pneumonia. You can find sometimes that the respiratory rate is high. You can also find that the heart rate is high. You can also find that the temperature is high. All these things point you toward, I mean, you can be having pneumonia, but you can be like normal. I mean, in the beginning, you can be normal, but first, the problem is that when the pneumonia is advanced, it can cause sepsis. I will send you the criteria of the sepsis. Please mind that these criteria are very important to diagnose sepsis. The patient will be presented with cough and shortness of breath. Which questions to ask? Very similar to what we said. Any cough station. But do not ask about weight loss and loss of appetite and these things. Why? Because this is short complaint. The cough here started 2 days ago. So I think loss of weight is irrelevant. Okay? Cough and shortness of breath. Sometimes fever. No, not sometimes. Actually, they will be having fever. Sometimes chest pain. Which questions to ask here? Or which things to rule out? Here you have to rule out, unfortunately, the other causes of sepsis. Like what? Like UTI, like gastrointestinal infection or gastroenteritis. You'll ask any smelly or cloud urine. Why? Because the patient is having cough and shortness of breath and fever, and sometimes he is showing confusion. Sometimes. What if he is not showing confusion? In the beginning of the station, usually the examiner will give you news chart. You will pick up the news chart and you'll find that the patient is feverish and they're having high respiratory rate and the oxygen saturation is low. So the patient is having deranged vitals, which points you definitely toward sepsis. So now you already know that this patient is having sepsis. And when you enter or when you talk to the patient, you will find cough and shortness of breath and fever. Okay, cough and shortness of breath and fever. Your mission here is to rule out other causes of sepsis. How? Ask about UTI and gastroenteritis. 2 questions for each one, like smelly or cloud urine for the UTI, any alternating bowel habits for the gastroenteritis. Give me 1 minute, guys. I'm sorry. Okay, guys. So now you know that he is having, you need to rule out UTI, and as well, please, for me, try to rule out gastroenteritis because those are the other causes of confusion and sepsis in patients. Usually, the sepsis patient will be old age. Some things can point you towards sepsis. Who are the patients who are more likely to develop sepsis? Number 1, the old age patient. Number 2, the immunocompromised. So, age is one risk factor. Immunocompromisation is another risk factor. So in the past medical history, you will need to ask about any recent infection because more likely they are having respiratory tract infection or flu-like symptoms recently. Number 3, medical conditions. Which medical condition to ask about? Any high blood sugar, any smoker cough, because those are the most relevant things to be immunocompromised in an older patient. Number 4, do you take any medications? Do you have any allergy? Why I ask about allergy? Because I will be giving him antibiotics in a while. So the allergy in a cough stations or infection is vital. If you do not ask this question, you will fail this station. I know 2 people who failed the UTI station just because they did not ask about allergy. You have to ask about it. Okay, this is very good. You know what? Sometimes it depends on the station of the sepsis. Some stations the examiner will offer you in the beginning. He will tell you, doctor, read your findings before proceeding to the patient. Some other times you will take history, and whenever you say, I need to check your vitals, the examiner will tell you, doctor, you have the news chart beside you on the table. So it depends. You know, I prefer that if the examiner tells you in the beginning, because now you know that it's sepsis. But still, if you do not know, which is highly unlikely, you still have to ask about it in the examinations portion. So now, is it possible that the examiner may stay quiet and no, Dr. Murad, I think it's not like a police inspection. It is not like a torturing exam. You know, if he stays quiet, this has only one explanation, that the examiner is sleepy. Because you know what? This is news chart. As a doctor in the real setting, you are supposed to find a monitor. So this is impractical. This is not practical to let you look for the news charts around you. He has to provide you the news chart whenever you ask about the vitals. And by the way, in the sepsis cases, he will provide you with a news chart. He will not only tell you that these findings are this and this and that. No, he will provide you with a news chart because they are quite crucial in diagnosis, and you will see right now. Okay, so now you will tell the patient after the vitals, you will tell him in the respiratory examination. In the respiratory examination, the examiner will give you that there is wheeze or crepitations usually, which means that usually the sepsis is due to chest infection. So this patient is having chest infection currently. I need to do some investigations. Which investigations, doctor? Please, I will tell them to you in a paper. Wait for this paper. I will tell you the sepsis approach in a while. I will make sure that I will send it to you tonight, even before anything. These stations are quite different and they are repeated too much. Okay? Okay. Generally, which investigations we will do for sepsis? You will do full investigations, full initials. Like what? Full blood count. This is number 1. Number 2, liver and kidney function test. Number 3, ABG. Number 4, blood culture. Number 3, serial lactate. If you forget serial lactate, you will get 1 or 0 in the management. Why? Because it can turn your diagnosis 180 degrees. So do not ever forget to mention serial lactate. We will also do some urine culture, so urine dipstick and culture, sorry. We will also consider doing chest x-ray. Very important to do chest x-ray here. Do not ever forget about it. And you can also order ECG. Okay? Okay. Why ECG? Because sepsis is life-threatening, so you can need to order all the initials. Okay. Disclose. You're having condition we call sepsis. What is this, doctor? Sepsis is our body reaction to a bug. Our immune system, instead of fighting against the bugs, they fight against our own tissue. Or instead of fighting against the bacteria, they fight against our own tissue. This leads to development of sepsis, or this destruction or the damage to the body tissue. What are you going to do for me? Number 1, this patient is having sepsis, so we need to admit the patient in the hospital. Number 2, I will involve my senior. Number 3, sepsis 6. What is sepsis 6? Sepsis performa, 3 in and 3 out. What is the 3 in? Number 1, we will give him oxygen for his shortness of breath, which is in the use chart. Number 2, we may need to give him IV fluids according to his blood pressure and his serial lactate level. Which fluid? Sometimes the examiner may ask you which fluid. You will say 500 milli of Hartmann solution. 500 milli of Hartmann solution. Always remember this in any sepsis station. Number 3, we need to give him antibiotics according to hospital protocol and after discussing with the senior. If the examiner asks you which antibiotics, you can say according to hospital protocol. If he insists to listen from you, here it is chest infection. In any sepsis, we give broad spectrum antibiotic and selective antibiotic. Broad spectrum here will be IV co-amoxiclav, 1.2 gram. IV co-amoxiclav, 1.2 gram. And selective is IV clarithromycin, 500 milligram. Clarithromycin is selective for chest infection. Co-amoxiclav is broad spectrum against any infection for sepsis. Okay, one thing I forgot is a patient, or the patient may tell you, why did I get the sepsis? You will tell him because you were having chest infection. Okay, why? Okay, so simply sepsis is because of number 1, fever. I said sepsis because of number 1, fever. Number 2, tachycardia. Number 3, maybe hypotension. Number 4 as well could be tachypnea. And why chest infection? Because he is having cough and shortness of breath from the history, and from the examinations he is having wheeze or crepitations. So you're having sepsis due to chest infection. Why sepsis? Because of 1, 2, 3, 4, because of the vitals. Why chest infection? Because cough and shortness of breath from history, and the crepitations from the examination. Okay, so we said about the 3 in the management of sepsis. What are the 3 out? 3 out are simply blood, routine bloods that we mentioned about. Number 2, urine and chest X-ray. Number 3, serial lactate. Serial lactate is very important. And if possible, you can also need to monitor the urine output by attaching the urinary catheter. So 3 out are number 1, routine bloods and urine. Number 2, chest X-ray and serial lactate. Number 3, urine catheter or urinary output. This is a sepsis case due to chest infection. In some other station, it can be in a telephone call. Actually, I had this station of the telephone call with a care home. Care home or any telephone call, guys, you start it like this. Hello, I'm Dr. X from this department. Am I calling, for example, the care home? They will write you in the task that you are calling the care home. And you will find the task beside you on the table. So you will say, I'm calling this care home. They will tell you, yes, doctor, you are calling this care home. Okay, nice to call you today. So how can I help you? Or sorry, you will tell them, we are receiving or we have received a patient from Mr. XX from your care home. She will tell you, oh, okay, wait, doctor, for a minute. I'm going to check my record. By the way, this nurse will interrupt you many times because she needs to check the record. Why? Because she did not attend his illness. She was in a vacation, I think, or something. Okay, no problem, Dr. Murad, take your time. She was on a holiday and she did not attend the patient. So she just needs to check the recording every time you ask any question. So it is very similar history. Did he have any cough? Sorry, he was presented with cough and shortness of breath. You will ask about any fever. Okay, Dr. Ella, in data gathering in a care home, to get one in this station, this only means one thing. I will tell you. By the way, I got 11 in this station. I got 4 in data gathering. I got 3 in management and 4 in the personals. The good thing is that your interpersonals will be high. And the problem is that your data gathering will be messed up because the nurse will keep interrupting you all the time. So you know the patient is admitted because of cough and shortness of breath. So you need to elaborate them in details from the nurse. She will tell you, I don't know, I don't know, I don't know. Yet you still need to ask her about everything to show the examiners that you know how to elaborate the cough and shortness of breath. And fever as well. What are the associating symptoms like the other associating symptoms for the cough? Chest pain, shivering, loss of appetite, night sweats. What are the differentials? You know that this patient is having cough and shortness of breath and fever, and most probably is having sepsis. So the differentials could be the UTI and the gastroenteritis, because these are the other causes of sepsis in the old age. Move to the past medical history. Again, same as the previous station. Lifestyle, smoking, and please do not also forget if there is any close contact to someone with similar illness in the care home. Okay, okay. Now move to the examinations as a previous station, vitals, general physical, and respiratory examination. You will find the vitals showing you sepsis. Now move to the investigations. We may need to do chest x-ray to him as well. The examiner may or may not show you chest x-ray. Now the examiner will stop you and ask you, doctor, what's your diagnosis? You will say that I'm suspecting sepsis due to chest infection. Why, doctor? You will say sepsis because number 1, fever, number 2, tachycardia and tachypnea, number 3, you can also say low oxygen saturation, and the patient is confused. Confusion is sign of sepsis as well. And why chest infection? Because the patient is having cough and shortness of breath from the history and from the examination with wheeze or crepitations. What are you going to do? I'm going to admit the patient. I'm going to ask my senior to come and review, and I need to do the sepsis performa 3 in and 3 out right now. Like what we said, 3 in, oxygen, IV fluids, and antibiotics. 3 out are bloods and urine, number 1. Number 2, urine output. Number 3 as well, serial lactate. Okay, what will you do next? What will you do next? Okay, after the end of 1 hour, I need to assess the serial lactate. You know, if the serial lactate is above 2.5, this means that we may need to resume the IV fluids. However, if the serial lactate is above 4, this means that, and the blood pressure is below 90, the systolic blood pressure is below 90, this means that we need to call critical care team because the patient may develop septic shock. Again, in the end of the first hour, we may need to assess the serial lactate or the lactate. If the lactate is above 2.5, we need to resume IV fluids. If the lactate is above 4 and the systolic blood pressure is below 90, this means that the patient is more likely to develop septic shock. So we need to call the critical care team. What is the critical care team for your knowledge? They are a team of medical professionals who come bedside to the patient, like just beside the patient in his bed. They are having all the facilities, oxygen, IV fluids, all the facilities which are, and the gowns and masks and everything to treat the patient with septic shock, because the mortality rate in this disease is 50%. So they need immediate treatment. Okay. Let's speak about the last two stations. I will sum them up in less than 10 minutes. And I'm sorry for the elongation today. We wasted much time in the beginning. I promise from the next days it will be quite faster and it will be quite enjoying. I know that all of you are tired and all of you are bored, but it will take us only a few minutes to finish. And I will provide you with the remaining 5 scripts: bronchogenic carcinoma, sepsis with a care home, and as well, I will provide you with the acute coronary syndrome and angina. Yes, Dr. Mahdi, what's wrong? You can increase the timings, Dr. Mahdi.
Hello, no. Just one moment, please. Actually, in my station, the person, he asked about his daughter, Angela. Where is Angela? Where is Angela? He asked for at least 5 to 7 times. So what should be my approach in that condition?
Okay, this is very good. Actually, this station is a sepsis when he's having COPD, if I remember. This guy was having COPD, I mean long-standing COPD. And this guy is old age patient, and he asks you, where's Angela? I will ask him first, who's Angela? He will tell you, doctor, she is my daughter. And where does she live? He will tell you, doctor, she lives far away somewhere. He will tell him, definitely, we can call her for you in a while. I'm going to ask our colleagues or my colleagues to call her for you. Meanwhile, I'm going to ask you a few questions to help you to feel better.
Okay, thank you, bro.
You know what, Dr. Mahdi, this patient is quite sluggish. This patient will not answer any of your questions. This patient will barely reply. You know this. He will barely reply.
He replied to me.
Yeah, I mean, he replied
me.
Oh, yeah. Yeah, tell me.
But unfortunately, I told him that, okay, I have already called Angela and Angela is on the way. I told him this lie. And that's why I got 0 in management.
Oh, no, wait. After saying about Angela, what did you say?
I said I have called Angela. Angela is on the way. I told him.
So you did not say the management?
Yes, I said management. Actually, I said only up to antibiotics, not everything.
So why did you get 0 in the management? Why?
Actually, I didn't maintain sepsis 6. I didn't mention.
Okay, what is
for this?
Oh, okay, so this is a problem. But what's wrong with Angela? I mean, I didn't get your point. What's wrong is that you mentioned Angela?
Exactly. When he asked about Angela, I told him that Angela is on the way. I told him this lie. I didn't have any idea at the situation, but that's why I am asking you this question.
No, Dr. Mahdi, Dr. Mahdi, I need to know one thing. What did he mark you down? I mean, the examiner. You know what? If you say Angela is coming on her way, you'll be marked in the interpersonals and in the management as well.
Yes.
Sorry, the
I got 3.
Okay, so in the consultation, in the issue.
Yes.
Were you marked in the issue?
Actually, I didn't follow that. I didn't notice their feedback, but in my mark is 1, 0, 3, ultimately 4.
And the pass mark was probably 5 or 5 point something.
Yes, pass mark is below 6, 5.41, something like that.
Because this
pass mark is very low.
Yeah, the pass mark is okay. This station is challenging. Why? Because I know some people from some academies, they enter and they tell you're having pneumonia. You know, so the vitals are the vitals are quite brightening. The vitals are dancing before your eyes. The vitals show you that this patient is really serious, and you still say pneumonia. No, it is beyond pneumonia right now.
Okay.
That's why. Okay, Dr. Mahdi. In this station, you will say that Angela is on her way. By the way, we would discuss this sepsis, this other sepsis, in some other day as well. I'm just discussing the easiest sepsis right now. Do not worry. I'm not forgetting to include them.
Okay.
So simply the confused patient. If the confused patient asks you any question, please always answer okay, I'm going to call her. I'm going to ask my colleagues to call her and come. Definitely, you need her. by your side. Meanwhile, I need to ask you a few questions to be in a better position to address you. In this patient, or in the many mental state examination, or in the warfarin with learning disability, or any confused patient, do not be smart. Just say anything else. Did you call Angela? No, you did not. Did you know where's Angela? No. So definitely I'm going to ask one of my colleagues to come and take her number from you, or to call her for you. You know, you are saying this because you cannot waste your time to tell him, okay, we will call her. So he will tell you, doctor, okay, call her. No, just tell him that I'm going to call her after this consultation. Or I'm going to ask someone to call her for you right now. So meanwhile, I need to ask you a few questions. So if Angela is coming, no, Angela is not coming. Maybe he's already confused and Angela is somewhere else. So please do not lie to the patient and provide something that you are not sure about. Just say, I'm definitely going to call her, and I'll ask one of my colleagues to call her for you. Definitely you need her help and support. But meanwhile, I need to ask you a few questions if you don't mind. He was sluggish, he was answering a little bit slow. He may be wasting your time by his slowness or his sluggishness, but this is not a bad thing, because in sepsis stations, the management is very easy. Sepsis 6, 3 in, 3 out. Never remember this. In 2 occasions, we need to do 3 in and 3 out. What are the 2 occasions? The sepsis and surgical emergency. Sepsis and surgical emergencies. We need to do 3 in and 3 out. Okay. The last 2 stations are quite similar, the acute coronary syndrome and the angina. Okay, let's speak about the only difference between the 2 stations, because all of you know about the ACS and the angina. All of you have studied them before. Barely few people know the difference between the ACS and the angina. What is the difference between the ACS and the angina? Let's speak. Number 1, the ACS is a general term. You do not know yet what is the reason of the heart problem. It could be MI, it could be unstable angina, it could be anything. So at the moment, you do not know what is the reason. Okay? So usually the patient of the ACS was having chest pain. Sometimes it can be more than 30 minutes. Some other times less than, it depends. This chest pain was quite incapacitating and debilitating. How? It was chest pain which was quite squeezing, and the pain was referred to the left arm and the jaw, sometimes to the neck as well. And the chest pain was not relieved by simple painkillers. And the pain was continuous when it happened. It lasted for like maybe sometimes 20 to 30 minutes. So he is not in pain right now. Okay. And one important thing is that this pain was worsened maybe by walking, or maybe worsened on its own, and not relieved by painkillers. Character was 7 to 8. So definitely this is typical chest pain. What are the other symptoms? He could give you sweating. He could give you shortness of breath as well, like any heart patient. Okay, okay. One important thing here, if someone is presented with chest pain, we need to ask some things which can be associated to the chest pain, which you will say to the patient. You will say to the patient, when someone is presented with this complaint, we need to ask a couple of questions which can be related to it. So by any chance, did you have any 1, 2, 3, 4? Okay. Okay. So you will ask about, as I told you, sweating and shortness of breath. What are your differentials here? Okay. What are your differentials? Simply pulmonary embolism, okay, and trauma and chest infection. Pulmonary embolism is very tricky, and it can be misconfused, or it can be confused simply with the ACS. What is the difference? Number 1, the difference is that the pulmonary embolism can occur like maybe 2 days ago, but the chest or the heart disease, the ACS, definitely the patient will not stand it. He will come in the same day. even after it's over. The other difference is that the character of the pain. This is squeezing pain, the ACS. But the pulmonary embolism is usually tightness or heaviness, because it's mainly, or even stabbing sometimes, because it's mainly like due to lung problem, not due to heart problem. But believe me, even if I say to you many differences between them, the only difference will be the investigations, which is the cardiac enzymes. We will speak about them right now. So, chest pain, shortness of breath, and sweating. Associating symptoms, you can ask about heart racing, nausea, vomiting, for any chest pain. What are your differentials? Pulmonary embolism and chest infection. For pulmonary embolism, I'm going to ask as a patient, have you had any redness or swelling in your legs? Because this is DVT, which could lead to pulmonary embolism. For chest infection, I'm going to ask as a patient, do you have any fever? Very simple. And you can also ask him, have you injured yourself? Trauma. In past medical history, have you had any similar episodes in the past? Very important to ask, because similar episodes can point you toward either angina or MI. Because usually the patient with ACS was having similar episodes in the past, but he ignored them. But this time it's worse than the previous episodes. So please ask about previous episodes. Number 2, recent health. Did you have any fever or flu-like illness recently? Number 3, medical conditions. In the medical conditions, please ask about high blood pressure, high cholesterol, in any heart problem. Ask about high blood pressure, high cholesterol, and high blood sugar. Those are the 3 things never to miss in any heart problem, or if you are suspecting heart problem. Do you take any medications? Do you have any allergy to any food or drugs? Family history. Family history, usually the patient is having family history of heart problem. His dad died of heart attack 15 years ago. Please, when the patient tells you this, say, I'm so sorry for that, we'll definitely help you. Because he's worried because of what happened to his dad. Lifestyle. Lifestyle is the core of any cardiovascular problem, as I told you a few minutes ago in the SAH. Ask about smoking, but here you can ask about it in details, because actually this patient is a smoker and imbalanced diet and physically inactive, and he's drinking much alcohol and he's having much stress as well. Okay guys, okay. Let's end this hustle by asking him about the examination. Which examinations? The heart examination and respiratory examination. In any chest pain, you need to do these 2 things: cardiac or heart examination and respiratory or chest examination. So, heart and lung examination or chest examination. You will find nothing in the vitals or in the examination, but in the investigations, you need to do routine bloods and ECG and chest X-ray. For any chest pain or cough, you need to do ECG and chest X-ray. Again, for any chest pain and cough, you need to do ECG and chest X-ray. Again, ECG and chest X-ray. If someone forget about them, he will pay £5. This is one of the limits. Okay, what's next? The examiner will give you ECG paper. Don't panic. Why do not panic? Because as of FY2, even if you did not pick the ST segment abnormality, which can be even not present, because in the ECS, sometimes the ECG is normal. So if you do not pick up the ST segment abnormality, it's fine. Because still, for any ECG, you have to ask your senior to come and review it. The Constitution says that the ECG must be confirmed by 2 people in case of heart attack. And by the way, even if they confirm it, you know the problem? The problem is you cannot diagnose anything unless you perform cardiac enzymes. So you will tell, I need to do some investigations, routine bloods, including heart enzymes, chest X-ray, and ECG. The examiner will give you ECG, and he will tell you the heart enzymes are waiting. Very good. Now you are telling the patient that you are having a problem with your heart. Which problem, doctor? You will tell him that the pain you are having is due to probably a problem in your heart, which happens due to the disruption of the blood supply to the heart muscle. What are you going to do for me right now? Okay, this is a challenging question here. Very challenging question. Why? Because this differs from one person to another or one patient to the other. Many people are confused about the ACS management. Why? Because of one reason. Because they think that this patient should be started on the treatment right now. Actually, you will keep the patient only in the hospital right now, under observation. Why keeping the patient under observation? I will tell you why. Because you are still waiting for the cardiac enzymes. The cardiac enzymes still need to be released within 6 to 12 hours. Right? Right. So, we're going to keep you in the hospital because we are waiting for your blood results. And we are going to give you some medications. Which medications, doctor? We're going to give you strong painkiller because you're having this pain. Okay. Number 2, you're going to give him aspirin. Why? You're going to give him aspirin to prevent him from heart attack. So far, you do not know that he is having heart attack. So you still need to give aspirin. You know, in the acute management of any heart problem, you need to give aspirin. Just tell him we're going to give you blood thinner to prevent heart attack. Doctor, but I want to go home. When the patient tells you, I want to go home, what you will say? You will definitely ask him, may I know why you want to go home? Why? He will give you, I'm sorry to say, he will give you a strange excuse. For example, I'm not comfortable. This means that the patient is not aware about the implications of this. So simply tell him, I'm glad that you, he will tell you, doctor, I'm fine, I just want to go home. So simply tell him, I'm glad that you're fine. But the thing is that, you know, we need to wait till we receive your blood test results. That's why we need to keep you in the observations. Doctor, but why are you going to keep me in the hospital? I need to understand. Why? Because these blood test results will take some few hours. And we need also to repeat your ECG, series of ECG, every few hours. So the blood results take few hours, and we need to repeat the ECG, serial ECG. Remember, in any heart problem, we need to do serial ECG. Okay, what will happen next? By the way, this patient is not high risk, which means that this patient is only having high blood pressure. Yet he's not at high risk, like he's not very high risk to develop heart attack. So you can send this patient at home. But you know what to do? You will give him, as I told you, many aspirin. Definitely, if the investigations, the blood results, and the ECG stay normal, you can send him home. But you will discharge him with aspirin, many aspirin, number 1. Number 2, you will give him GTN, glyceride trinitrate. Why? For the pain. You will give him this GTN and you'll advise him to take 2 puffs under the tongue. Within 15 minutes, the pain will be gone. This is number 2. So number 1, mini aspirin. Number 2, GTN. Number 3, we will give you some medication. One of them to reduce your blood pressure, the ACE inhibitor, and prevent the change in your heart muscle. We will give you also another medication to reduce your heart rate, to prevent more strain in your heart, the beta blocker. So number 1, mini aspirin. Number 2, GTN. Number 3, beta blocker. And number 4, very important, the ACE inhibitor. Okay? This patient needs to be referred to specialists. Why? He will be usually seen by specialists within a few weeks. And this will be done through the GP. So now you will discharge him, but you will tell him that he needs to see the GP within 2 days to review his medications that he is taking for the blood pressure. He's already taking medication for the blood pressure usually. So you will send him to the GP within 2 days, and the GP will give him an appointment with a heart specialist, usually within 2 weeks. Okay? Okay. What you will do, he will ask you, if I get chest pain, you will tell him about the GTN. If you get this chest pain back again, take the GTN and you'll be more comfortable. 1 or 2 puffs under the tongue. If you ever have time, you can give him some general advice about the lifestyle. Like what? You can advise about smoking and about diet and about exercise. Smoking damages the blood vessel. Diet, it's important to maintain a healthy, balanced diet. Try to eat like maybe steamed or grilled food instead of junk food. Also try to abstain from the sugar or fat food because this will put you at risk of building more weight and increase the blood cholesterol. Physical activity, try to be physically active, very slight physical activity like walking from time to time, 15 minutes on 2 sessions per day. What are the warning signs? If you develop chest pain which is not relieved by the GTN, or if you have pain at rest, come back to us. Pain at rest is unstable angina, and pain which is not relieved by GTN is MI. So please come back to us. So guys, this is a station, by the way, this usually doesn't come these days, this ACS. And this is a station which comes these days is differential diagnosis between ACS and pulmonary embolism. And I will explain it to you tomorrow as a first station in the day, inshallah. So, what is the difference between the ACS and the angina? So now we finished the ACS. Last session for today is the angina. Usually this patient is presented to the GP. This is number 1. While the ACS patient is presented to the A&E because the pain was quite severe. The angina, he was just having this pain a few times ago. So he is here to check on himself. In the angina, the patient will give you episodic chest pain which is cardiac in nature. How cardiac? Simply squeezing pain, refer to the left side and to the jaw, and relieved by rest. Arrested by physical activity and relieved by rest. He will tell you literally, doctor, I'm getting this chest pain every time I climb the hill. Or every time I'm walking my dog. So this pain is coming in episodes. It comes and goes. And nothing relieves it except rest. It goes away on its own by rest. It came like 2 or 3 episodes before. This is typically angina, stable angina. This is the only difference between these 2 stations. The number 1 station is very bad chest pain, which lasted for 30 minutes in a row, or slightly less than 30 minutes. And it was not relieved by anything. And it did not come by any physical activity. It came on its own. But the angina episodic chest pain, which lasts for 10 minutes, and it goes on its own, it will be elicited by physical activity, and it is relieved by rest. Definitely stable angina. Same associating symptoms, same differential diagnosis, same past medical history, and same lifestyle as well. And the patient can be having stress as well. You know, stress itself can lead to MI. God forbid, so the 22 participants of today are at high risk of developing ACS because of this PLAB thing and the whole exams, which never end. I'm not predicting, God forbid, for all of us, but I'm just saying. Yes, unfortunately, Dr. Zaid. I was feeling that my heart was racing before my first attempt, actually. But the thing is that before second attempt, you will get to know, inshallah, when you enter again, you will get to know that if you are following the approaches that I'm telling you right now, because this is what I did to myself. If you follow this, and if you are quite natural, and if you are nice, which inshallah I will make you do by force, by the way. I'll make you do by force when we are practicing together. All of you. If you do this, I am sure that this exam will be the easiest exam to you. Because those guys are subjective. They are looking for someone who's going to comfort the patient and talk sweet. They are not stressing on all the knowledge that we are saying. Okay, so the only difference in the angina is that you will tell the patient that you're having a problem in your heart. What is the problem? You will tell him that I'm suspecting a problem we call angina, which happens due to disruption of the blood supply to the heart, which gives you this sort of pain that you're having. Why did I have it? Now you can speak. For example, if he's having high blood pressure, you will say. If he's having smoke, he will say. If he's having family history, you will say as well. So it is picked up from the history. What are you going to do? Here comes the difference between the angina and the ACS. The angina patient, you can give him mini aspirin and the GTN spray, okay? And you can give him also the beta blockers and the ACE inhibitor, but you can send him home right now because he's in the GP. You do not need to do ECG and cardiac enzymes right now. You will not have them in the GP. So what you can do is that you can send him home right now, and you can give him an appointment with a heart specialist within 2 weeks. What will the heart specialist do? They will do further investigations to him. Which investigations? Number 1, ECG. Number 2, 24-hour ECG. Number 3, echo. Again, ECG, 24 hours ECG. Number 3, echo. While the ACS, he will refer him to the specialist for further investigations. Which investigations? Only echo and 24 hours ECG. So the specialist in the ACS, his rule was to confirm or to find the cause, to find the cause. But in the angina is to confirm that it is angina and to rule out other causes. So again, here you can send him home right now. He does not need to wait at the GP clinic because no cardiac enzymes can be done here. So you can send him home, okay? And you refer him to specialist because you are GP, you are the one who give appointment to the specialist. So you refer him to specialist within 2 weeks, and the specialist will do further assessment to him, which assessment? ECG and the 24-hour ECG and cardiac enzymes and echo. What is the treatment? Again, mini aspirin, GTN, ACE inhibitors, beta blockers, and lifestyle advices. Similar to the ACS. Okay. And by the way, you do not even need to do the ACE inhibitors, I'm sorry. You'll just give beta blockers because of the heart racing. So the ACE inhibitors are not necessary here to be given. There is no risk of change or remodeling to the heart, the angina. So just give beta blockers, GTN, and mini aspirin. You will be provided with the notes to these 4 stations. I will provide them to you early in the morning as well. And tomorrow, while explaining the stations, I will provide you with each station in separate. For example, we will explain tomorrow the rest of the chest pain stations and the tiredness stations. I'll be providing you with a script instantly. Today, we have given 14 stations. I do not like this. I need 20 stations. I may make the pace faster a little bit in the next few days. That's why, because today was a start, I was a little bit asking and involving you when it comes to history taking and this. But starting from tomorrow, you should know everything. That's why you should read how to take history today from our previous note from yesterday. And for today, you are going to read only the bullet points, please. The bullet points for the stations that are provided. Do not remember any script. The time brew by an hour, and please start an hour. Oh my God. So you want the session to last for 6 hours? Are you serious, Dr. Messi? 6 hours? No way. I think other members will never accept that. Yeah, okay, it would be lovely for me and you, but other Dr. Ella is not accepting. Who else does not accept? By the way, I do not mind. You know, Dr. Messi, in my previous sessions, I used to stay for 8 hours sometimes. We used to start like from 1 p.m. and we ended at 9 p.m. I remember very well, there was a session for all the combined stations. We finished it after 7 or 8 hours. Yes, definitely, it will be difficult. And by the way, you do not need to be taught everything. You only need to be taught how to approach each set of scenarios. For example, to be taught how to approach the cough scenario, how to approach shortness of breath scenario, how to approach the chest pain scenario, like this. And the findings, this is my mission, to give you the findings and the difference between each station. Thank you all for listening today. Anyone has any question? Yeah, I think from tomorrow I will give 10 minutes break or 15 minutes break after the first 2 hours. Just forgive me for today. It was quite lengthy because it was the first session and I need to stress on your compliance because some people were sleeping, so I need to check up on everyone. Yeah, from tomorrow we will start on time, inshallah, I promise. One more thing, your feedback, please. Your feedback on the WhatsApp group. Write me the feedback and what we can improve in the next few days, inshallah. Write it in the WhatsApp group. Don't be lazy and write the review in the WhatsApp group right now. Okay? Write it right now, even if it's just two words. Just write the review and the thing that we need to improve in the next few days, because I need to consider them from you. Okay? Okay. Thank you, everyone. I hope you liked it. Okay, Dr. Maria, I'm really feeling pity. I'm feeling sorry for you. Dr. Yemi, did you enjoy the session? Which points are missing, Dr. Zaid? Which points are missing? Because it seems to me that I'm going to kill you right now. Tell me which one.
Yeah, to be frank with you, this one, when you said about the history, and then after that, the psychiatric history, there is a point of the investigation and the physical examination, and then the management. Yeah, I couldn't able to find it in my notes.
Yeah. No, tell me, because I think there is one paper was missing, but I sent it later.
I will check that. I will check it after the point 11 in psychiatry.
Yeah.
And then you jump to the management. There is a point regarding the investigation and the examination, I think. Yes.
Okay. Okay. I will check it right now. I will check it.
Right.
Okay, Dr. Kashi, for that. Okay, if anyone wants to leave right now, you can leave. I'm going to answer the questions only right now. Detailed approach for any telephonic station. First of all, you will start, I'm Dr. XX from this department or from this hospital. Can I confirm that I'm talking to the, can I confirm your name, please? Sorry. She will tell you, yes, doctor, I'm Jenny. I'm nurse from this care home. Nice to call you today, Jenny. Actually, I'm calling regarding Mr. X. He was referred to us from your care home. This is the telephonic conversation with the care home here. But in other stations, for example, like when you are doing the telephonic conversation for the missed blood sample, or for the patient, or for a mother who is worried about her son, you will say, hello, I'm Dr. XX from this department. Can I confirm your name and date of birth, please? She will tell you, yes, doctor, my name is X and my date of birth is X. That's great. And can you confirm your address for me, please? Why I'm confirming the address? Because I may need to send an ambulance after a while. So I need to confirm the address right now. You do not know that the phone call may be cut or interrupted at any point. So you need to ask for the address right now at the beginning. After that, you will tell her, so how can I help you today? Like any station. So this is the beginning. I am XX from this hospital or from this department. Can I confirm your name, please? She will tell you, yes, doctor, my name is XX. I'm the mother of X. Nice to meet you. Can you confirm your date of birth and address, please? She will tell you the date of birth or birth of address. By the way, you'll find these information written on the table or in the task behind the phone. So you do not need to bother yourself about them. Okay? Okay. Anyone has any question or any doubts? I'm here. Because after a while, I may call someone to come and practice with me one station. And by the way, today I agree that I will start with Dr. Zaid. And tomorrow, before starting the session, Dr. Masih will practice with me one of the stations from today. Dr. Zaid, your punishment will be that you will practice with me one station from today right now. Without any script.
Dr.
So
Ahmad?
now?
Not now, just in a few minutes. Just give me a break, okay? Yeah, who is speaking?
Dr. Ahmad?
Yeah.
Is in the last station about the angina one, is there any need of treadmill-based ECG, like stress-induced, because the history that stress increases the pain?
Yes, actually, this is a good point. You know, 24 hours ECG and the treadmill test, they will be done under specialist supervision. Okay,
yes.
So when you refer him to the specialist, what will he do? The echocardiography, the myocardial perfusion scan, and the treadmill stress test. Just no need to say about them. Just say that he will do some serial ECG or 24-hour ECG and some ECG under physical activity and echocardiography to detect the abnormality or the problem in the function of your heart.
Yeah, sure. Okay, thank you. Thank you, Dr. Ahmad.
Okay, you are welcome, Dr. Yasmin. It's my pleasure. Okay. Surgery 6 is still far, Dr. Lamia. I'm not just giving you a quick hint about this right now, but I will speak about them later, inshallah. Surgery 6 simply are number one, you will put 2 lines and the catheter and nasogastric tube. This is 3 in. 3 out, you will put your, the 3 out are urinary catheter and nasogastric tube and cannula. What will you give? You will give the patient IV fluids. You may need to give the patient antibiotics and painkiller. So IV fluids, antibiotics and painkiller. And 3 out are cannula and catheter and nasogastric tube. Well, if you speak for more than 4 hours, you'll be tired to air. But I'm not that tired actually because I'm used to this. The thing is that I need to take a little bit break and I will be back. Is anyone or does anyone here need to ask about anything?
Dr. Ahmad, in this angina station, patients are very pet to ask the question, can I go to work?
Okay, if he asks you this question, actually, going to work usually after the angina, it may take him like maybe 2 weeks. It's better to stay apart from the work for 2 weeks. And as well from the driving actually, it is better that he continues driving like after a few weeks. Why? Because it will be better for him to take the break after 2 weeks, or he will be not like tired after 2 weeks to take the break.
No, that is for SCS, but as the activity aggravates the pain, and that's why patients are worried to go at work.
Yeah,
so
sure.
Question,
he needs to stay at least from work at least for 2 weeks till he sees the heart specialist, at least.
Oh, good. Yeah, thank you.
You're welcome. Yep. So anyone needs to ask any question, please. It will be better if you open your mic. Write the surgery, guys. I will write everything. I'm sorry, it's all my mistake. I'm really sorry if I wrote something which we do not talk about right now. I will write it later, I swear. I will write it in a while when we discuss the surgery stations. By the way, this surgery 6, you need them only in the interception station and in the IO, which is the new station, the intestinal obstruction. So we will write them before the surgery stations, because before starting every set of scripts or every set of stations, I'm going to give you some quick hints before starting them. So it will be done on the day of surgery. Usually, for that not to be annoyed right now, I'm going to write it for you right now. 2 lines. And meanwhile, while I'm writing it, if anyone needs to ask any question, please tell me. Tell me everything. Tell me everything. If anyone needs to ask any question right now. 2 lines. After. I cannot write, by the way, in one message because it is not here on Zoom nor Skype. 2 lines catheter and nasogastric tube. Those are the 3 out. The 3 in are IV antibiotics, IV fluids, and painkillers in some cases. So, anyone needs to ask anything else here? You're welcome, Dr. Murad. By the way, Dr. Murad, tomorrow you'll be the one who will sing with me after the session. So be ready. I will need you to be very awake tomorrow. Okay, deal, Dr. Murad? Dr. Murad? Okay, deal done.
Brother.
Yeah, who's speaking? I'm sorry. Who is speaking? Wait. I think Dr. Murad is speaking. Hello? Hello? Who's speaking here? Someone was asking me one question. Anyone has any question right now? Okay, everyone. So, are we done for today? Actually, I enjoyed the first session.
Hello, brother.
Yeah, Masi. How are you?
I'm fine. Hope you're fine too.
I'm fine. Yeah, tell me.
I just wanted to ask that you just gave us associated symptoms of each and every particular presenting complaint.
Yeah.
like for cough and for chest pain or for headache. So, like, do you have a note of all of these symptoms, associated symptoms of a particular presenting
Okay.
complaint?
I do not have for the moment, but I can provide you right after the course, like maybe after the 15 days course. Why? Because I need to prepare them. It needs writing.
Yeah,
Period.
sure. No worries, buddy. But it would be helpful, I would say.
Yeah, sure. I can provide it with you. Me myself, I did not follow them, but I kept them in my mind. Like I used to correlate the symptoms together, but definitely I can provide them to you. But I mean, do not
Please take
follow
your
them blindly because sometimes they can change.
Okay.
Just follow the approach, like maybe if there's chest pain, then we need to ask about cough, fever, shortness of breath. If headache, we need to ask nausea, vomiting, and fever, and rash, like this.
And once again, what was the pattern of the management? First of all, examination, then initial investigation.
This is not management, brother. Data gathering,
So
examination and the investigations are part of your data gathering. The management starts with number 1, disclosing. Number 2, explaining the diagnosis. Number 3, saying what we are going to do in terms of investigations. Number 4, you will start the treatment. For the treatment, you will number 1, admit. Number 2, senior review. I mean, it differs from one station to another, of course. Number 2, senior review. Number 3, symptomatic management. Number 4, definitive management. And number 5 is safety netting and warning signs.
Okay, and could you please tell me what exactly is safety netting?
Safety netting. Usually, safety netting is not used too much in the history-based stations. But safety netting usually when you are telling why? Because you will not have time to tell it to the patient. But if you ever have time, you will tell the patient the safety netting. For example, if he's presented with chest pain, you will tell him that the safety netting that he needs to take this GTN whenever he experiences this pain. This is that you are safe doctor. You are safe doctor because you do not.
Yeah, this is what the examiner are, I think, exactly looking for, that we need to be a safe doctor.
Yeah, that's why you need to stress on the fact that he needs to stop smoking and he needs to take the GTN spray whenever he's having this chest pain. And he needs to keep his blood pressure under control. Warning signs is that if he develops any of the symptoms, again, come back to us. Or take the GTN spray.
Or any side effects.
Yes, any side effects of drug or any symptoms of the relevant disease. So come back to us.
All right.
Okay?
Okay, thank you.
Was it clear, Dr. Masih?
Yeah, sure.
Dr. Masih, if you have any doubt, share it with me instantly.
Okay. Not at all at the moment, but if I will have anything,
no problem.
I'm going to share.
And please, by the way, it's better if you ask me in the questions, like after the session, or even after the session of the next day, or even before the session, but not in private. Because in private, you will get lost. I may not be able to answer your questions, and they will be lost in the messages. Okay?
Sure.
I mean, no, I'm speaking about everyone, not Masih only. So, guys, do you have any questions so far? I hope it will